I think it's time already.
A very good morning to one and all present. I, Prashant Bhardwaj, extend my warm and heartiest welcome to everyone. Today, I am fortunate enough to be a part of the World Conference on COVID and Critical Care. I'm very excited to be part of this amazing session that we are going to have today. Now, all without taking much time, welcome our moderator for the debate session, Dr. Anirban Home Chaudhary. Sir is currently working as Director Professor and Critical Care Expert, GB Pant Hospital, New Delhi. Sir is Principal Investigator at ICMR, DBT, Assessor, NMC, NBE, Examiner, AIMS, ILBS, NBE, WBUHS, Expert Committee, UGC, DCGI, Associate Editor at JOACP. Without any delay, I request Sir to start the debate session and kindly introduce our eminent speakers. Thank you, sir. Over to you, sir.
If my recording is not playing, I can introduce verbally.
It's playing, sir. Check audio, please.
Opinion of the House, comprehensive auditing of our actions during the first and second wave will be helpful during future COVID waves. And in this debate, we have member of the Treasury, Dr. Sumit Ray, who will be speaking in pro of the motion, and we have Dr. Kapil Zirpe, who will be speaking against the motion. Both Dr. Sumit Ray and Dr. Kapil Zirpe needs no introduction. They are very distinguished and well-heard speakers over a long period of time. So without wasting further time, I request the member of Treasury bench, Dr. Sumit Ray, to present his arguments.
Hello, ladies and gentlemen. I will be speaking on comprehensive audit of healthcare response in COVID. It will help identify future strategies. I'll be speaking for the topic, and not only will it help future strategies, actually comprehensive audits of healthcare systems has already helped us, and I'm going to tell you how it has helped us in dealing with the COVID pandemic. So before understanding how it has helped us, we need to know what audit is. And audit is defined in healthcare as a process used by health professionals to assess, evaluate, and improve care of patients in a systematic way. And audits measure current practice against a defined or desired standard. It forms part of clinical governance, which aims to safeguard a high quality of clinical care for patients. And this interesting editorial, which came in clinical audit from the King's College Hospital, London, it's a very interesting headline there: auditing in the age of COVID, waste of resources or an opportunity we cannot afford to waste. And in that they write, the editorial writes that if clinical governance, of which COVID is a fundamental component, is an essential part of all aspects of modern medicine, and particularly in the uncharted waters of the ongoing COVID-19 pandemic, surely its importance is even more. And the sheer scale of the response to the COVID pandemic is very well suited to basically, have more of the audit process to actually understand what is happening. And it is not just, I will be using the past continuous tense in this because actually audits have already been done, which are already helping us, as I said. And as I said, it's heartening that the research and cross-border pooling of exercise of expertise has already happened. And this has already led to lots of lives saved. And sharing of knowledge through the audit process is a way of going forward in our global response to the pandemic. So this auditing process and the sharing of information started pretty early in the COVID pandemic. Initially, within few months, we had lots of data from China and Italy. And if you say this is one of those studies in JAMA, more than 72,000 patients looking at the clinical epidemiological picture of COVID, telling us what to do, how the clinical processes develop epidemiologically, how it spreads. In Italy, from Lombardy, they forecast their early experience, and from there, they already started prioritizing what needed to be done, the containment measures, what had been the ICU admissions over the past 2 weeks, what was the need, what kind of needs were there to improve surge capacity, and forecasting further demand in the ICU. And that was a clarion call, not only for their system, but for all of us across the world, how to go about dealing with this. This was the beginning of the whole audit process. And what has impressed me most among the audit processes is the ICNAC data, which is the Intensive Care National Audit and Research Center data from UK, the NHS UK. They started out with their first report in March 2002, and I watched it very, very closely during the whole COVID pandemic, particularly the first search and the kind of audit and collection they did is huge in different based on the demographics of patients, medical history, the indications, the severity of illness, the ethnicity of patients. Are they from deprived sections of society or not? Outcomes by patient characteristics, medical history, indicators by acute severity, depending on did they receive respiratory support or renal support. Outcomes in terms of length of stay, mortality, organ support for all patients by ethnicity, and also how patients did, those who got advanced respiratory support, like if you see, and they compared it with patients who compared it with previous patients who had other viral pneumonias, and also organ support recipients based on renal support, and also patients getting multi-organ support also. So what was the outcome, what they needed to change, and all this was already documented in large volumes from the beginning of the pandemic. And if you see, by 23rd October 2020, they showed by this data collection and analysis and tweaking their therapies, tweaking the distribution of resources in the UK, they increased survival from 61% to 69% in a 6-month period. Not only that, they were able to reduce the 28-day mortality for almost all groups, for different age groups, for gender, for different ethnicities. If you see, this is before 31st August and this is after 1st of September, and this is data till the 23rd of October 2020, and this is in orange. As you can see, all of them have improved significantly. What they probably could not improve is those outcomes of patients who had severe comorbidities, and they did a rethink of what to do about it. And they also looked at patients who were mechanically ventilated within the first 24 hours. What was their outcome? They were able to improve that to a certain extent only. And again, they tweaked their ventilatory needs and which patients to be intubated early, which not to be intubated early. And by 15th October, which is this week of 2021, they have already improved survival from the first 1 year to the next 6 months. The last 6 months, the improvement in survival is almost 12%. And not just, it's all across, it's across age, as I said, ethnicities, body mass index, multiple deprivation levels, different patients with different deprivation levels, severe comorbidities. Across the board, they have been able to improve survival. Invasive ventilated patients within 24 hours, all the survival has improved over this period. So this part of this initial data was published in the American Journal of Respiratory and Critical Care Medicine, AJRCCM. And I'm comparing the first pre-peak and the post-peak period of 2020 that the data has. And it's very interesting. Use of invasive ventilation, which was almost 75% in the first 24 hours, decreased by a third to 42%. And at any point of time, the invasive ventilation came down from 85 to 61%. And this was based on the data that they found of outcomes based on invasive ventilation. And the 28-day mortality, in spite of a reduced, with the same severity of illness, a reduced invasive ventilation actually decreased by 10%, absolute reduction. And the length of stay also reduced significantly. So there was an editorial in the same journal on this article, and they found that the mortality and they emphasized the fact that progressive decline in mortality from 43 to 33% over this period of time. And not only that, it also brought into question the early institution of invasive mechanical ventilation of patients in COVID, which was the common practice early in 2020, which was supposed to be based on the best practice, which was already there, and also the fear of aerosol generation by NIV, risk of PCLE, etc. And actually the reduction in the rates of invasive ventilation, which was reported in this article, mirrors actually many of the experience of us clinicians in some way or the other. And we relearned how to use therapies like NIV and HFNC during this period. And many of the trends which were reported in this study are consistent with what happens to a system under extreme strain, and in which improved outcomes, and I'm quoting them, are achieved partly by the processes of care. That means auditing, understanding what needs to be changed, processes of care rather than magic bullet therapies. No expensive therapy seems to have helped in COVID yet. Mostly it has been improvement in processes which have helped, and that has come through audit. And the other strength of the paper, they say, and they give a kind of an ovation to the ICNAG, because the ability to stand up and maintain comprehensive, high quality national data at a time when resources to care for patients were at their most strained. In spite of that, they were able to maintain the audit process, and which was a very important part of how they were able to improve outcomes in England. So what do we need to do in India? Some of it has been done, but at the public health level, we need to have audits for therapies that use, like convalescent plasma, steroids, overuse of steroids in the outpatient OPD basis, leading to mucormycosis, probably antiviral use, anti-inflammatory use, leading to secondary infections, delivery and availability of care, like hospital ICU beds, ventilators, NIV, etc. Cost of care, public spending versus private spending, insurance, the role of insurance. Was there indebtedness increased during this period? What were the outcomes in terms of cases, rates of hospitalization, at ICU admissions, mechanical ventilation, mortality, case fatality rate, etc. And to find out which systems or which states or which cities did better, and to try and follow the positives of those models, and to not follow the negatives of other models that we use. And at the hospital level, we need to audit our own therapies, the same therapies that I mentioned earlier, and the outcomes in our hospital, and the processes we used to either improve, or what happened to the processes that we changed during the process of treating COVID. Like, just to take a case in point, one of the therapies to be audited is a plasma therapy. In October 2020, the Placid trial, the Indian trial, and before that, other trials already had shown that there was no advantage of convalescent plasma in therapy, but the continuous pressure by certain groups, even politicians, Devendra Fadnavis got plasma therapy. Satyendra Jain got plasma therapy and claimed that it saved his life. And this is not the way how it should be done. That is why it is necessary to do audits to see how we perform. Also, there is this controversy or otherwise of, was Kerala a successful model? Was it able to, could Kerala flatten the curve? If you see, there was a peak of surge across the nation during May and June, where the April to June, which caused a huge amount of mortality because of the sudden rise in cases. Probably Kerala could flatten the curve to a certain extent, and that is why probably its case fatality rate is less than 0.5, actually 0.45, as compared to the average in the nation, which is about 1.3, which is 1/3 of the rest of the nation. Like Gujarat and West Bengal has 1.2, and Delhi has 1.7 case fatality rate, Maharashtra 2.1. But if you see in other terms, the cases per million and the deaths per million were higher in Kerala as compared to, say, Gujarat or West Bengal. But also you can see that the tests done in Gujarat and West Bengal were much lower, 0.4 million per million population and 0.2 in West Bengal, while Delhi and Kerala had much higher testing, more than the actually million population. So all these things need to be audited and analyzed and see which is a better model. How do we go about doing better? And that can only be done by auditing. And I go back to the first article that I quoted, and I quote again from them: the political debate about the effectiveness of response and the responsibility for such tragedies will surely rumble on for years to come. That means there will always be a political debate, and health has become a political issue because providing good health care is a political challenge which has to be picked up by the political, the powers that be. But against this backdrop, because of the political debate, we feel that it is easy to conclude that probably audit is not a priority. But that is not true. That is a mistaken view. And it is important that we do audits. And that is the only way forward to improve our delivery of care. And it is not magic which are going to improve our delivery of care. Thank you.
Thank you, Dr. Sumit. We have heard the good round of points from the member of the Treasury bench, Dr. Sumit Ray. Now I would request the member of opposition, Dr. Kapil Zirfe, to put forward his views.
Share it. Is it okay?
Yes.
Yeah.
So I heard Sumit, and I can understand the way Sumit was speaking. It was very difficult for him to defend the audit. But let me see what I can speak. And I'm not repeating the definition. I'm not repeating the definition. What is the audit says? Audit is a summary of clinical performance of the healthcare over a specific period of the time. Please try to understand. It is a specific period of the time aimed at providing information to the healthcare professionals to allow them to assess and adjust their performance. Now, almost 1 year and 8 months have gone, and still we are discussing the clinical performance. Still we are discussing, trying to summarize the things we learn, we gone through, we publish. And if you heard Dr. Sumit, he has most of the shared data. It was not the ideal audits. It was the publications, it was the experience of the particular hospital or region or the nation where they have accomplished or compiled their data and publish it and try to come to the conclusion that this might help, might be ventilator strategy, might be convalescent plasma strategies, might be the drug strategies, may help in future. It was not sure. So particularly during the COVID time, audit was not an ideal thing because this particular pandemic pushes for the online. When it goes for the online, it loses its importance because the online audits are not so easy to perform. There are a lot of limitations for the online audit, for collection of the data, for the during such a pandemic when there is such a excessive load on the healthcare system. I'm not sure really how many health system able to cope up with that load and able to collect their data, analyze their data and share in a proper fashion. In a few of the Western countries, it was possible, but unfortunately, in developing countries like India or nearby countries, it was really the difficult task or the Herculean task to collect. So it is very difficult for making the audit and speak on the audit will help in future. For our part of the region is very difficult. Now, second, if you see we are talking about the clinical audit. What Dr. Sumit shared with us is most of they were the clinical audits in terms of the use of the drugs and the therapies and how we can in future reduce the mortality. One of the slide, probably the last slide, he mentioned that there has to be the strategies for the bed availability as well as oxygen availability. And we have came across during the second peak, what happened in India, what happened in our country. The whole system get collapsed. Though we had we did the excellent during the first wave, we had a good experience during the first wave. Most of our healthcare system were geared up to treat this particular pandemic, and we are quite confident that any wave in future will handle it in a better way, and all of a sudden everything is collapsed. So it is very bold to say that the audit may help in future. Now, if you see the few data available or the which are the published, this was in 2020, it was an article which was published comparing the first and second wave data. And if you see, this was a Tanmay Ghosh and it's from the ASISM. If you see what he is mentioning, there are 18 mutations in 7 genes. So unpredictability is huge. If suppose one particular wave has a particular presentation and the particular mortality with whatever the drugs available, second wave doesn't correlate with the first wave. And that's what we observed during the second wave. That everything get collapsed with the Delta variant. And we came very late that this was the variant which is causing the severity of the disease is different, and patients are coming in a short time in a load. So I don't think the audit will help in this particular COVID virus. I can understand in other diseases audit may help, but particularly regarding with the COVID, it is very difficult to say that the audits will help in the future way. Now, this was another data from the March 2021. This is recent. It was from the Spanish, this thing, the comparison of the first and second wave. Now, what they mentioned that the results of the present study show that hospitalized patients in the second wave were younger. Again, nobody was sure whether the old age or younger age will be more of this, and that was predicted in India also. What happened? We never find any age difference in the second wave. Had a lower mortality. In fact, in India, we had a higher mortality. So it doesn't correlate. For example, if I try to implicate this data in our setting, then it will be completely misguiding. Our patients were older, our patients were more comorbidities, our patient had a higher mortality rate, and the most of the time treatment was not very much effective. Here it is mentioned that it is more effective on less institute. So probably COVID surprised us everywhere in the world, and it will surprise in future also. Then they have very clearly mentioned that the future perspectives are difficult to predict. So on 31st of March 2021 in published study, they are saying that it is not possible to predict anything in future, and then how we can say that any audit will help in future. And this was another Indian study. This was a preprint version is available from the North Indian study. Again, what they have found, no significant demographic difference in between the two waves. It is contradictory to the Spanish study, indicates the role of the other factors such as the Delta variant. So every blame was pushed on the variant. Now nobody talks about what we gained the experience from the first wave, what we learned from the first wave, which drugs were effective in the first wave, how can we utilize the oxygen therapy in a better way. They are saying that because of the change in the Delta, change in the variant, like a Delta variant, it is very difficult to comment on that. And that is what the problem with the audit in COVID. So I came across, this is one of the best trajectory I came across, which highlight how unpredictable is the situation. And this was in 8 July 2021. This was the title was After Pandemic, the Perspective on the Future Trajectory of the COVID-19. So look at the unpredictability of this virus. And that's why I am not sure any audit will help anywhere in the world. So there are three possible scenarios. So there is no one or two scenarios. There are three possible scenarios for the future COVID after 1.5 years, almost 1 year and 8 months have gone. Already we faced the two waves. Other countries face the third, fourth wave. And what is the trajectory? Either it will remain the same situation. In fact, it may be the most worrisome, and we will not gain rapid control in coming few months or year. It is a nightmare. Second possibility, it may turn into the epidemic. That is a hope. And the third scenario is transition to the endemic. That is a additional hope. So nobody's sure. Everybody talks in terms of the possibilities. So I don't know how audit is going to help in this situation. And what are the gaps he has found overall for the next trajectory and for the comparing and the formatting the guidelines? First thing is epidemiology. What he said, what are the effects of the geographical and socio-economic variation in the vaccine coverage and disease on the ability to convert the pandemic into endemic epidemic is doubtful. Now, for example, US and most of the countries had one particular vaccine, and now they are facing the Delta variant, and their situation is worse than the first two waves. So how much that particular vaccines is protective against the Delta variant? Doubtful. Then second part is what is the contribution of the immune suppressed population to the rapid evaluation of the COVID-19? Nobody knows. We need to find out answers for that. From the virology point of view, what is the mechanism by which virus adapt to the different hosts and thereby crossing the specific barrier? Nobody knows. We need to find out. Like one of the previous paper I discussed, they say that why younger individuals were affecting, why the recurring patients are suddenly deteriorating and requiring the oxygen is clear in current situation in 2021. That is a very worrisome situation. Then regarding the immunology part, what are the correlation of the protection of the vaccines and the natural immunity? Again, we started discussing the third dose of the vaccine, booster dose of the vaccine. So nobody knows how much protection, which population will get the protection, what is the herd immunity, what is the vaccine offer immunity, whether we'll get certain innate immunity. Nobody knows. It is all assumptions and the hopes. What is the impact of the antigenic drift? Again, we need to find out. What are the criteria for the renewal boosting of the vaccine? We don't know. Still, we are discussing, and all governments are confused over this particular issue. Surveillance globally, we need to further assess the diagnostic and the deep sequencing tools to establish the continuous and sustained goal surveillance of the disease and variants. Seriously lacking.
Debate session of web conference, which the topic is between COVID and regular ICU cannot be avoided often in long run in pandemic times. Our chairperson for the session is Dr. Prashant Verma, Professor, Department of Anesthesiology and Critical Care.
Thank you so much, sir, for such a wonderful session. Now we will start our next thematic session from 1 p.m.
Thank you.
Thank you.
Hi. A very good afternoon to one and all present over here. I, Dr. Anushi Saxena, extend my warm and heartiest welcome to everyone. I am honored to be a part of this prestigious World Conference on COVID and critical care. Now, without taking much time, let's start with our first thematic session of the day. I would like to appreciate the presence of our distinguished chairpersons for this session. Our first chairperson for today is Dr. Tapas Kumar Sahu. He is a senior consultant and head at Critical Care Medanta Hospital, Ranchi. Our second chairperson is Dr. Venkat Raman Kola, head of Department of Critical Care, Medicine Care Hospital, Banjara Hills, Hyderabad. Dr. Jasbir Chabra, consultant critical care, ventilation lead critical care unit, Lancashire, Teaching Hospitals, NHS Trust, UK, and Dr. Muktanjali Arya. She is a senior consultant in microbiology, head lab services, and infection control at Deep Hospital, Ludhiana. I welcome you all. Now, without losing much time, I would like to request our eminent chairperson, Dr. Muktanjali Arya, to take over the session and introduce our first speaker, Dr. Kedar Toskar. Over to you, ma'am.
Doctor, you're muted. Dr. Muktanjali, you're muted.
Okay, sir,
Am I
no
audible now?
problem.
Yeah.
Yes, ma'am, you are audible.
Yeah. Thank you very much. A very good afternoon, all. Let me first thank Dr. Ruta sir and the organizers for inviting me. It's my pleasure to introduce Dr. Kedar Toraskar. He'll be talking on drug treatment in COVID, the sequential introduction and withdrawal. He is Director Critical Care Unit, Wockhardt Hospital, South Mumbai. He's an IDCCM teacher. He runs DNB program, been focus trainer for point of care ultrasound and member of Maharashtra Government Task Force for COVID-19. It's my pleasure to introduce you, Dr. Toraskar, and now over to you.
Thanks, madam. So I think in the next 12 minutes or so, we'll be talking on drug therapy, sequential introduction and withdrawal of these drugs. So timing is everything in COVID. So I think without wasting much time, we'll go to the one. Audio, I think I can't hear it.
Hi everyone, I'm Dr. Kedar Toraskar, and in the next 12 minutes, I'm going to talk about drug therapy in COVID, the correct timing, sequential introduction and withdrawal of drugs. So why timing matters in COVID? As you all know that COVID is a deadly and novel virus and it affects multiple organs in different phases. We have been facing it since the last 20 months now. It has mainly 4 different phases. The first phase is the viremia phase, in which the virus replicates actively. This is followed by the inflammatory phase, in which you have inflammatory manifestations of the disease, and it is divided into late and early inflammatory phase. And then the cytokine storm phase, in which you have a cytokine storm, and this may overlap with the late inflammatory phase, or this may not be present in some cases at all who have a mild or moderate course of the disease. And finally, once the infection abates, you have the post-COVID syndrome, in which you have the sequelae of the disease. Now, why is it important? Why are all these phases important? Now, specific interventions and especially drugs, which I am going to talk about in the next 10 minutes or so, we work in a specific time frame in the above mentioned phases. That's why the timing is important. Now, this chart or schematic diagram shows you these different phases which I was talking about right now. The first and foremost is the incubation period, which lasts for around 1 to 5 days or 7 days. And this is followed by the symptomatic phase in which the virus replication increases exponentially. Now, the patient may present with symptoms like fever, cough, malaise, headache, diarrhea, and these may be the early phase in viral replication. This is followed by the early pulmonary phase in which you have shortness of breath. The patient's breathlessness may progress, and this is followed by the late pulmonary phase in which you have immune dysregulation, macrophage activating syndrome, and maybe overlap with the cytokine storm. Now again, COVID is a prothrombotic phase. That's why you have thrombophilic manifestations of the disease, which may come up here in the early pulmonary phase, and it may extend into the late pulmonary phase. Now, why is it important? Because the treatment approach changes here. Okay, so you have antivirals which work best in the viremia phase in the first 1 to 8 days, which is followed by the inflammatory phase. That's why the anti-inflammatory, especially the steroids, may work best in the early pulmonary phase. Now, word of caution, you should not use steroids in the viremia phase because it may prolong the viral shedding. And also do not use steroids in an unwarranted manner when it is not indicated. If the patient doesn't have hypoxemia, please don't use steroids. Now, steroids are best used when you have exercise desaturation. And how do you know about it? You have to do a 6 minutes walk distance test, which we are all doing in our patients, in which you have desaturation of around 4 to 5% from the baseline oxygen saturation. Now, the baseline oxygen saturation may be absolutely normal, but they may the patients may desaturate after the walk. Now, that is a time when you have to start steroids. That's the earliest indication to start steroids. And of course, then you may require to start immunomodulators, that is the IL-6 inhibitors like tocilizumab or the JAK2 inhibitors like baricitinib, in patients who have cytokine storm. Now, classically, you have to use them as early as 24 hours of the onset of the cytokine storm. What about anticoagulation? We'll discuss that later in details when I go to my presentation. So these three phases are very, very important. The viral replication phase, that's a viremia phase, followed by the early pulmonary, late pulmonary, which may be overlapped with the cytokine storm phase. Now, why this diagram? Why this picture of VVS Lakshman? He was a great timer of the ball in cricket, and as in cricket, COVID also is timing in COVID also is very, very important. If you miss out on the timing, either you lose your wicket, but in COVID you may lose your patient's life. So it's a totally different ball game as compared to cricket. Everything is at stake in COVID. Now, too early and too late. Now, what? That's we have to decide. It should not be too early. It should not be too late. And that's why optimal timing in COVID is very, very important. We're going to talk about these drugs. So the game changers, I'm not going to talk about each and every drug which is used in COVID. You may land up having loads and loads of drugs which are used in the pandemic. Now we are going to talk about the game changers. So what are the game changers? First and foremost are antiviral, followed by the monoclonal antibodies, which are the new kids around the block, followed by steroids, which were the main game changers and are still the game changers right now, as the recovery trial stated. Immunomodulators, that is tocilizumab or baricitinib, and of course, last but not the least, are anticoagulants. So let's come to the antivirals first. So you have different antivirals which are not very promising, but of all of these antivirals, of course, remdesivir had shown the maximum promise, but it doesn't have evidence to back it up except for the Act 2 trial. But yes, we are still using remdesivir to good effect. And we have, of course, favipiravir and again the new antiviral on the block is molnupiravir. Now, it has shown good results in the phase 2 trials. Phase 3 trials have been conducted, and we still have to get the data of that. So antivirals are best initiated in the first 3 to 5 days because the best results are in the viremia phase. And the duration of treatment for favipiravir is around 7 to 14 days. So you can withdraw that after 7 to 14 days because the viremia phase is technically over after 7 days. And of course, 5 days for molnupiravir. Remdesivir is to be used for only 5 days. The initial trials showed that it could be used for 10 days, but comparing 10 versus 5, the debate was closed there because 5 is as good as 10. So do not use remdesivir beyond 5 days. And the most important time to use remdesivir is as early as possible. The 3 to 5 days time period from the onset of symptom is the best time to start remdesivir. Now, it can be also used for unremitting fever beyond 5 days in moderate to severe category with hypoxemia, but it's useless to start any antivirals once the viremia phase is over beyond 8 days. Now, so the bottom line is early use, no benefit if used beyond 10 days of symptom when the viremia phase is already over. What about monoclonal antibodies? Now we have 3 MABs which have been approved. The ones which we are using in India is casirivimab and indivimab. That is the regeneron cocktail, antibody cocktail. You have balanavimab and estivimab also combination, which is not available in India, and strovimab, which is also not available in India, but other countries are using these. So what about monoclonal antibodies? When do you start them? Again, antibodies are best started in the first 3 days. The best results are in the first 3 days from the onset of symptom. So they should not be used in inflammatory phase when the patient is already hypoxemic. And there are few trials which are ongoing in hospitalized patients. So we still need more data on that, whether they are really helpful when patients are hospitalized or those patients who require oxygen. What about prophylactic use? The FDA has now finally approved the antibody cocktail as post-exposure prophylaxis for certain individuals who are at high risk for acquiring COVID-19 infection. And if they are infected, and they would have been a high risk for progressing to very serious illness. So these are 2 indications where you can use monoclonal antibody even for post-exposure prophylaxis in high-risk patients. Let's come to the game changer, steroids. Should not be used in viremia because it is harmful. We have seen a lot of general practitioners, physicians using steroids on OPD basis in the initial viremia phase also, and that led to a lot of complications, and these patients really got admitted and became very bad. So no steroids in viremia phase. They have to be restricted to not more than 10 to 14 days. That's very, very important. Okay, longer period of steroids is going to cause more complications. And there is increased incidence of secondary bacterial and fungal infection if used in high doses beyond 2 weeks. That should be kept in mind. There is a doubtful role in post-COVID AIDS fibrosis, still no evidence based there. What is the dictum? Short course, low dose is the recommendation. High dose steroids are positively harmful, not to be used. The spades of mucormycosis which we saw were because of these unwarranted use of high dose steroids. Mortality benefit obviously in hypoxemic patients and those who are mechanically ventilated, which the recovery trial proved. And of course, off-label use in persistent inflammatory fever beyond the viremia phase when all the other treatable causes of fever are ruled out, but that's off-label use. Preferred agents, as we all know, dexamethasone 6 mg OD for 10 days or methylprednisolone 1 to 1.5 mg per kg daily. You can also use other steroids like hydrocortisone, but the evidence is for dexa and methylprednisolone. Now let's come to the immunomodulators. Again, IL-6 inhibitors like tocilizumab or sarilumab are used. In India, we use mainly tocilizumab. Some centers were using itolizumab, which is a CD blocker, CD24 blocker. JAK2 inhibitors like baricitinib has shown promise now, and you have evidence to back it up. Now, when do we start these? It can be harmful if it is given to patients with active infection and immunocompromise, as with steroids. Best used within the first 24 hours of cytokine storm or respiratory decompensation. So whenever you have a respiratory decompensation, you should use these immunomodulators within 24 hours of the cytokine storm. So they are definitely harmful in viremia. Do not use them in viremia. The best results, again, as I said, are worsening hypoxemia within 24 hours of respiratory decompensation. Clinical criteria have to be used, not just IL-6 levels. Isolated IL-6 levels should not be used. Imaging criteria like X-ray worsening, CT scan worsening, ultrasound score, lung ultrasound score worsening can be used. Now, biomarkers like other biomarkers like ferritin, CRP rising trend should be used along with the IL-6 levels. And of course, you have to rule out secondary infection. So if you have procalcitonin which is negative, that really helps. What about baricitinib? This is a JAK2 inhibitor. It's an option for patients requiring high flow oxygen or NIV. And previously it was used and licensed only with remdesivir, but now it can be used without remdesivir and even in patients who are on dexamethasone or other steroids. Now, baricitinib should not be used in patients who have already received an IL-6 pathway inhibitor, and the dose is 4 milligram once a day for up to 14 days, 10 to 14 days. That's the dose. What about anticoagulants? Now, bottom line, not indicated for mild ambulatory category of patient to be used with moderate to severe cases with COVID coagulopathy. All ICU patients should get low molecular weight heparins either in a prophylactic dose or therapeutic dose depending on the clinical status on admission. And extended anticoagulation can be used for patients with low flow or COVID coagulopathy or with patients who have confirmed DVT and PU. Now, prophylactic dose for those patients who have a normal D-dimer. Now, D-dimer has a good negative predictive value. We should not use anticoagulation based on just D-dimer reports. That's wrong. So D-dimer has a very good negative predictive value. And those patients who have a normal 2-point compression ultrasound. Therapeutic dose can be used in patients with documented pulmonary embolisms and deep vein thrombosis. And it has to be continued at least for 3 months for documented DVT or PE. Now, transition to DOACs, that is direct oral anticoagulants on discharge, can be made if there are no contraindications to have a better compliance. Now, obviously, LMW is preferred. Low molecular weight heparins are preferred. Unfractionated heparin in renal failure. Fondaparinums for patients with suspected HIT. And as I said, switch to DOACs on discharge. Now, summing up, first is do no harm. So whether it is drugs or other interventions in COVID, we should do no harm. That should be the dictum. And again, reiterating, starting the right drug at the right time is very important. If you're too early or if you're too late, then your patient will not do well. Okay, and you will have a negative outcome. Thank you very much. And I thank the organizers of this wonderful conference for giving me this opportunity to talk on this forum. And I would go ahead for the question and answer session. Thank you very much again.
Thank you so much, sir. Any questions? Any questions? Now we move forward, and I would request our eminent chairperson, Dr. Venkatraman Kola, to take over the session and introduce our next speaker, Dr. Rahul Pandit.
Yeah, good afternoon, friends. To roll on the further proceedings of this session, I have the privilege to invite Dr. Rahul Pandit, who has been on the front line on the COVID management and task forces of not just Maharashtra, but also the country. And he's been the director of intensive care Fortis Hospitals, Mumbai, and is a visiting consultant to many other hospitals and a part of Australian experience and been a member of many task forces, and Honorable Supreme Court has appointed him as one of the national task force. I now hand over to Dr. Rahul Pandit for COVID management strategies, the success story he carried away. Over to you, Dr. Rahul.
Hi, friends. I'm Dr. Rahul Pandit. The topic I've been given to speak on today is COVID-19 management strategies, the success story. I thought I would pick up on a few success stories which we have had in our own unit, rather than actually talking elaborately around the entire globe, because we've had some of these mixed stories there, where some of them have been very, very clear that we've actually done exceedingly well. For example, some of the trials which we've had published, the recovery platform being one of the best ones in the world. And then we've had some of the trials which have actually been not so great. Also, the mortality reviews have been very, very difficult to assess. So I thought rather than going anywhere else, I might as well concentrate on what we have achieved in the last 18 months. So if I was to look at the three cornerstones which have helped me in improving the outcomes of our unit, the first one has been actually early identification of patients who are likely to deteriorate. Then, of course, the care of the patient, which is very, very important. And the third one is obviously avoiding complications. And these three papers from my unit in the last 15 months, 16 months, actually relate quite nicely to these 3 points which I mentioned. And I would like to sort of take each one of them in a separate way so that we understand where I'm coming from. So unmasking hypoxia in COVID-19, a 6-minute walk test. I think 6-minute walk test has been in place for last 20 years. However, its use and utility in COVID-19 only started coming up in the first 2 or 3 months after the COVID-19 pandemic came in. And we realized that it seems to be a very good challenge for our cardiorespiratory system to actually exhibit whether it has got the capacity to actually provide the body needs or the patient becomes hypoxic. So very early on in the pandemic, we actually published this data, the 6-minute walk test, and we found that it's a simple and effective tool to assess silent hypoxia. But that's what has been killing patients very, very often in COVID-19. We were able to unmask hypoxia in these patients by asking patients to go through a 6-minute walk test. We were able to identify the ones who are likely to deteriorate. And a simple intervention, like admitting them early or starting them on steroids right now at that point when they actually failed the 6-minute walk test, helped us quite a lot. And we all know how it is done. We ask a patient to walk for 3 to 6 minutes, 3 minutes for patients who are above 60, or else it's 6 minutes. Patient walks, and if the saturation falls below 94%, or if there is a drop of more than 3% from the baseline, we say that this 6-minute walk test is a positive test for hypoxia. And you now need to basically look at this patient as a hypoxic patient, start them on steroids early. If you are a believer in antiviral, start them on remdesivir or favipiravir. And of course, nowadays, you need to think of admitting them and even thinking of monoclonal antibody at a very early stage, even before they fail a 6-minute walk test. So a positive 6-minute walk test may actually stop you from giving them monoclonal antibody. But if it's a negative 6-minute walk test, you may probably go ahead and give them monoclonal antibody. So we decided that we will adopt that as a policy. Every patient who was in home isolation, was in our wards, or before they had to be discharged, all of them had to pass the 6-minute walk test. And all of them had to have a 6-minute walk test which was negative so that they could be sent home safely. I think this is one strategy which has helped us quite extensively in making sure that our patients are safe. The second strategy has been our approach towards ventilation. So we had a very clear understanding from before that too much of oxygen is not good. We don't know whether hypoxia is bad. I mean, I would say severe hypoxia is bad, don't get me wrong, but mild hypoxia is bad. But we definitely know that hyperoxia is no good. So we started keeping saturations between 93 to 94% in an unmonitored environment. And in a monitored environment, it would go down as low as 88%. At any given point of time, the aim was to keep the saturation below 96%, never allowed to go below above 96%. And obviously, if with supplemental oxygen they remain hypoxic, we would put them on HFNC. We used awake prone quite extensively, just as the rest of the world did. And we were quite surprised that it actually helped so much, and often wondered what kept us away from doing it even before the COVID-19 pandemic struck us. So I think this is one of the learnings from this pandemic, a huge learning from this pandemic, that you can do awake proning for patients who are non-ventilated and still have reasonable oxygen saturation come up. Obviously, HFNC was our preferred mode of non-invasive ventilation. We could use HFNC quite effectively with cone ventilation. We could go up to a rate of around 50 to 60 liters per minute of flow, and FiO2 closer to 100% as much as we can get. And obviously, it was all in a very, very closely monitored environment. If the patient did not improve with our set targets in a specific time period with the ABGs, we would not hesitate to put them on a mechanical ventilation by intubating and ventilating them. I think that strategy is one of the game-changing strategies. So we had a very clear motto: do not delay mechanical ventilation. If the indication for ventilation is clear, ventilate. If they failed HFNO or NIV with a target observation period, go ahead, intubate and ventilate this patient. And some of our targets for ventilation were on the left side of this column: altered consciousness, clear indication; risk of airway compromise, clear indication. If the pH was below 7.2, we would often go ahead and intubate these patients, as they would classify as a severe acidosis. If they remain hypoxemic despite a good trial of non-invasive, and hypoxemic as in PaO2 less than 50, or a PF ratio less than 150, or a saturation less than 90, despite good trial of non-invasive ventilation. And if there are signs and symptoms of respiratory distress by means of increased work of breathing. Just because the CT was bad, just because they had a low PF ratio of around 160, 170, we would not intubate them. So these were some of the clear guidelines which we utilized for intubating these patients. Once we intubated them, we had a clear protective lung strategy. It was 6 ml per kilo ideal body weight tidal volume, plateau pressure to be kept below 30 centimeters of water. We would allow permissive hypercapnia, would allow the CO2 to rise up as long as the pH remained around 7.2, 7.25. And we tolerated a relative hypoxemia with a PaO2 between 55 to 65, and or a saturation around 88 to 92%. And we were very clear that these are the parameters which we are going to follow no matter what. These are some of our outcomes. If you see on the left, this is out of 514 patients. This graph here on the left clearly demonstrates that we had a sizable number of patients who had a PF ratio less than 200. And obviously those who were more than 200 were not intubated. Majority of them were non-nasally ventilated. But we had a chunk of around 130 odd patients who got ventilated, who had a PF ratio less than 100. And obviously when they were ventilated, they spent an average more time in the intensive care unit and on the ventilator, as opposed to the non-invasively ventilated patients or oxygenated patients. So it was very clear that if you remain intubated, you're going to spend more time in the ICU. But this is where the whole important outcome is. A total of 514 patients here on the right side of your column at the bottom. We discharged 464, and we had 50 who died. That brings our mortality to exactly just under 10%, 9.9% of ICU mortality. And out of the ventilated 133 odd patients, we had 34 who succumbed, and just under 199 were discharged. This is the data of the first 514 patients which we had with us. And you could see that our ventilator mortality was only 25%, which was way below some of the reported world across statistics, which were 40%, anywhere between 40% to 80%. And I think that's why I said it's very difficult to actually quantify what are the success stories. And I thought this is a reasonable ventilatory outcome, and it should be sort of demonstrated out here. The third strategy which we very clearly had was low-dose steroids. 5-methylprednisolone in the dose of 1 milligram per kilogram, which was equal to 6 milligrams on dex. We would use tocilizumab only in the first wave in a very specific group of patients. No other immunomodulator was used at all. No baricitinib, no infliximab, Sepsivac, nothing of that sort. And emphasis was on good care. We used drugs when they were necessary, but not as a substitute for good care. Quite often I was seeing that just because the patient is hypoxic, instead of ventilating, you would give them tocilizumab, 1 dose, 2 dose, and that was actually causing a lot of harm than any good. These are some of our results again from the same study. If you were using steroids, the mortality was obviously most of our patients received steroids. The mortality was more or less same, 10%. Even in patients in who we used tocilizumab, we did not find that the mortality made any difference. It was still 50%, after 10%, beg your pardon. And in the antiviral group, we had a mixed bag of results there. Another thing which was very well-meantly open and very clear to us was we saw not one, not one case of mucormycosis in our patients. And I attribute that to the strict steroid protocol and the glucose control, which was nurse driven in our ICU. And you could see here, this was our protocol, day 1 to day 6, and then we would wean the prednisolone off from day 6 to day 10. And by day 10, all patients would be off the intensive care, off the steroids in our intensive care unit. I think that made a big difference. We had absolutely no cases of mucormycosis in our patients. So I think, my friends, if we bring up these 3 simple things, identify them early, give them good care, and avoid complications, I think each ICU has a potential to have a very, very good success story. So these would be my summarizing points. Identify them early, trial them with HFNO or NIV, whatever is there available. Timely initiation of mechanical ventilation remains the important point, and avoid unnecessary drugs. Please do not use them as substitute for good care. Use them when it's necessary and continue giving good care. Thank you very much. I'll be happy to take up questions.
Hello, good morning, Dr. Wing. It was an excellent presentation, sir. Just wanted to ask you, when you said timely initiation of mechanical ventilation, is there a particular time frame you waited for? What criteria did you use to say, well, we have failure of NIV or we have failure of high flow nasal specs?
I think Dr. Rahul Pandit is not in the live session.
Possibly then I think we'll leave it to the end required.
Yeah. So we'll go to the next session.
That's brilliant.
Yeah, now I invite Dr. Jasbir Chhabra to take over the session and introduce our speaker, Dr. Sachin Gupta. Over to you, sir.
Thank you so much. Thank you very much for inviting me to oversee this session. Our next speaker is Dr. Sachin Gupta, who is the head of the critical care medicine specialty at Narayana Super Specialty Hospital, Gurgaon. He's been examination secretary for the Indian College of Critical Care Medicine. He's also the member of the research committee of the Indian Society of Critical Care Medicine and a member of the editorial board of the Indian Journal of Critical Care Medicine. He's been a fellow of the American College of Critical Care Medicine and is a fellow of the Indian College of Critical Care Medicine. He's been an examiner and a teacher at various courses and has got more than 40 publications to his credit, including being author in several chapters in critical care books. Thank you very much, sir, for gracing this occasion. I would invite you to start your talk.
I would first like to thank the organizers for having me here. The topic of my talk is the utility of extracorporeal therapy in severe COVID, and I would be sharing my experience on 75 patients. The new COVID-19, which was caused by SARS-CoV-2, has been identified by WHO as an international public health emergency. The symptoms such as fever, cough, dyspnea, myalgia, fatigue, and dehydration, they develop in mild infection. But when these symptoms worsen, they become more severe in nature and become pneumonia, acute respiratory distress syndrome, or multi-organ failure in certain patients. So why should one think of cytokine removal? A significant proportion of COVID-19 patients which are admitted to the ICU, they develop a CRS known as cytokine storm, which is associated with capillary leak syndrome and ultimately leads to lung, heart, and kidney dysfunction. Among other mediators, interleukin-6 typically increases together with other acute phase reactants like ferritin and C-reactive protein, and this is considered as a risk factor for developing ARDS. The clinical picture is characterized by severe hypercoagulability. So if you look at this image, the SARS-CoV-2 ultimately leads to COVID-19 infection, and which releases the reactive oxygen species and causes cell death. It also causes macrophages trigger and activated T cells, which releases cytokines. Once these cytokines increase in number, it leads to a term called cytokine storm, which again triggers the inflammatory cascade, and patients develop acute respiratory distress syndrome, bacterial infection, sepsis, and then multi-organ failure and ultimately death. This cytokine storm affects every possible organ in the body, whether this is lung, GI tract, brain, cardiovascular system, liver, kidney, microcirculation, and even the ophthalmic area. SARS-CoV-2 infection is associated with an inflammatory cytokine storm, and this is primarily characterized by an elevated level of interleukin-6. But the relationship of interleukin-6 and mortality remains very unclear even in the dying patients. If a patient has an insult in the form of infection, SARS, surgery, trauma, burns, there is a host response and PAMs and DAMs are released, and this leads to a sepsis cascade. How do we tackle? We give them basic primary resuscitation in the form of oxygen, fluid therapy, catecholamines. Then we also look at a source control if possible. If the organs do continue to fail, we give them organ support like mechanical ventilation, hemodynamic support, renal support, nutritional support. But if the patient continues to deteriorate despite all these basic therapies, then one can look at adjuvant therapies like extracorporeal support. There was an editorial which was published which looked at what is the role of extracorporeal organ support in intensive care. So they said that it is a sepsis-like syndrome which often occurs in COVID, either because of the virus itself or because of a superimposed bacterial infection. And since there are no clear-cut pharmacological approaches that have been found to be useful, the new extracorporeal oxygen support therapies like heme adsorption and hemoperfusion with new sorbent cartridges which are designed to remove cytokines and other circulating mediators should be considered. So when should one think for cytokine removal? And based on certain international guidelines as well as not so much documented experiences, they have come up that cytosorb therapy should be used in following criteria. If the patient has pronounced vasoplasia like severe septic shock where the noradrenaline dose is high, more than 0.3, or the lactates are rising, and this is after there is no response to a standard therapy. In such patients, cytosorb can be initiated as early as 6 hours of the admission of the patient. Patients with moderate ARDS and all patients who are having an indication for ECMO or extracorporeal life support, patients developing acute kidney injury stage 3 and almost heading towards a CRRT or H score suggesting diagnosis of secondary HLH. The best time to give any extracorporeal therapy would be phase B, where the balance between the pro-inflammatory and the anti-inflammatory has gone wrong, and there are more pro-inflammatory markers in the system. And this is the time when your cytokine adsorption devices will help the most, although this is very difficult to put it on a patient. What are the options available? So cytosorb is there, Oxyrif, which is a CRRT based circuit, and Hemophil is there. I would be sharing my experience, which is primarily based on the utility usage of cytosorb. Cytosorb is a biocompatible, highly porous polymer bead, and it can remove a wide range of toxic substances from blood and fluids, and based on pore capture and surface adsorption. This can be used as a standalone filter in a normal dialysis machine, but can also be used along with CRRT circuit or along with any other hemodialysis circuit. It works on the principle of a cytokine sweet spot, which means the area where the maximum cytokine levels are there, as per the weight, which is the kilodalton if you are looking at. So IL-6, IL-10, so all pro-inflammatory markers are at its peak, and it filters out these kilodaltons from 10 to 65 kilodaltons are being filtered out by cytosorb, where majorly all the cytokines have been filtered out, and this is the principle of cytosorb therapy. Now, if you look at our experiences, we gave cytosorb only in patients who were severe COVID in nature. We did not offer in mild to moderate because these patients did not deteriorate that much. We had 117 severe COVID patients in 4-month time frame, and out of these 117, 52 patients were on ventilator, 45 patients were on NIV or HFNC, and 20 patients were on non-rebreather mask, and this was primarily because of non-availability of either of the devices. right? So there is no standard criteria for initiating an extracorporeal therapy. If you look at various literature, everybody has given a different value of biomarker at which they did cytosorb, and based on our experiences, we realized that these are the biomarkers when the patients benefited most by offering them a cytokine therapy. So we looked at a CRP of more than 150, IL-6 of more than 125, LDH of more than 500, ferritin of more than 250, and a PF ratio of less than 150 as the initiating point for any extracorporeal therapy. Out of these 75 patients, we offered 123 sessions. So patients with one session were 27, and in 48 patients, we offered 2 sessions of cytosorb therapy. All patients who were given cytosorb, it was continued for 12 hours, and it was always a standalone treatment, because we realized that even if you want to combine it with any form of renal replacement therapy, if the patient is hemodynamically stable and you are doing a 3 to 4 hour dialysis, then again disconnecting it and restarting cytosorb, it was a little taxing for the staff, and so we gave it always as a standalone treatment. Heparin infusion was given at 300 units per hour after a bolus dose of 2000 units if there were no contraindications. Otherwise, saline flushes were used to prolong the life of the filter for the desired duration. A 24-hour gap was always maintained between the 2 sessions of dialysis of cytosorb. The other treatment like steroids, anticoagulants, a broad spectrum antibiotic, PPI, and vitamin C were given to all patients whether they received cytosorb or they did not receive any cytosorb. Now, if you look at the results, which was biomarker trend, so we looked at the results at before the initiation of these therapy and after, and almost on a daily basis. So after 1 day, 2 day, 3 day, 4 day, 7 day, and at the end of 10th day, every single biomarker like CRP, IL-6, and ferritin showed a downward trend. So the starting point, the mean CRP of all these 75 patients was 178 before the start of the therapy, and it came down to 42 at the end of day 10. Similarly, the IL-6 was 182. The mean IL-6 was 182 before the start of the therapy, and it did come down to tell almost normal IL-6 at the end of 10th day. The ferritin also reduced by from 333 to 110, and there was a gradual decline almost on a daily basis. The best ratio that we saw was in the PF ratio. We started at a very poor PF ratio of 123, and we ended up at 278 at the end of day 10, and this is the mean PF ratio that we are talking about. Out of these 75 patients, 48 survived and 27 did not. So there was a mean survival percentage of 64 in patients who were offered cytosorb therapy. Now, we also looked at the other 42 patients out of 117 severe COVID patients. We did cytosorb on 75 patients. So the rest 42, we looked at all those patients among 117 who were on vasopressors, who had an acute kidney injury, and who underwent renal replacement therapy. And we compared it to the other standard therapy group where the similar subset was there. So the mean vasopressor duration was also lower in the cytosorb group as compared to the standard care group. So from 5.6 days of vasopressors to 7.8 days in the standard care group. Similarly, the AKI resolution was faster in the cytosorb group as compared to the standard care group, and the need for renal replacement therapy was lower in the cytokine group as compared to the standard care group, from 10.6% versus 21.4%. Other markers like the PF ratio, the PF ratio was better in 75 patients versus those 42 patients who did not who were not offered cytosorb. This was 212 versus 156, and this was at day 7. Then the mean ventilator days were 8.9 days in this cytosorb group versus 12.2 in the non-cytosorb group. Weaning from NIV or HFNC to a normal oxygen mask was 7.6 versus 11 points, almost a difference of 4 days. Similarly, the ICU length of stay was shorter by roughly 4 days, and hospital stay was shorter by roughly 6 days. And this was a major determining factor. So if I have to summarize our results, some cytosorb therapy was initiated only after initial resuscitation was attempted, and there was deterioration in patient's clinical state. For patients with only hypoxemia, cytosorb therapy resulted in gradual reduction in the ventilator requirements. All biomarkers showed a downward trend over a 1-week time frame. The weaning from NIV HFNC to oxygen mask or to nasal prong or to a room air was much faster. The overall ICU length of stay and the hospital length of stay was also less as compared to the patients who could not be offered the therapy. In patients with septic shock or AKI or both, timely application did help in faster recovery of organ failures, although there was no difference in mortality. Why did we get such a result? Although the results are very promising, but there is no head-to-head comparison between the two groups. And timing of application was the key, as we initiated this session very early in the disease, but it was individualized case to case. We did not believe that at 8th day or 10th day only the therapy should be started. And we realized that if you are waiting for the cytokine storm to set in and then offer the therapy, it does not help. So should cytosol be a part of the regimen? We would still say no, because this is a single center experience with very low patient volume and we require a bigger trial. To conclude, COVID-19 is a mysterious disease with no standard treatment regimen. Basic good quality critical care is the cornerstone in the management of these patients. But if your other therapies, your standard therapies are failing and you're looking at an extracorporeal therapy, then timely application is the key for controlling any dreaded cytokine storm and multi-organ failure in these patients. Thank you so much.
Thank you very much for a lovely talk. I think we'll have questions at the end, I believe.
Thank you so much, sir, for such a wonderful session. Now, are there any question answers you may ask the speakers?
There are a few questions that have been asked in the chat. Shall we ask those questions first?
Yeah, sure, sir.
So I think for Dr. Sachin Gupta, there's a question by Dr. Urvi Shukla. She's asking, did you monitor ACT on heparin infusion?
So after giving the first bolus of 2000 units, we did monitor the rise of the ACT, but as a standard continuing at 300 units per hour, we never monitored ACT on any of the patients. I think that was too low a infusion to actually raise the ACT to a dangerous level, but we never monitored.
I agree. Now, Dr. Urvi Shukla has another question. Did you give heparin and Clexane together?
So the day, so the day we did the cytosol, there were no low molecular weight heparins were given because we are continuing the therapy almost for 12 to 14 hours. So no low molecular weight was given that very day.
Fabulous, yeah. If there are any other questions that we need to ask, anybody else has any questions? That's great. Thank you very much for your talk. I think we'll go on to the next speaker. Thanks.
Thank you.
Thank you, everyone. It is all for our today's thematic session 1. Now our next thematic session 2 will start from 2 p.m. So.
Thank you. Thank you.
Thank you.
Thank you.
Thank you. हजरत मेरे कोई
A very good afternoon to one and all present over here. I, Dr. Arushi Saxena, extend my warm and heartiest welcome to everyone. I am honored to be a part of this prestigious World Conference on COVID and Critical Care. Now, without taking much time, let's start with our second thematic session of the day. I would like to appreciate the presence of our distinguished chairpersons for this session, Dr. Anand Nikhalje, who is Director and in charge ICU, MGM Medical College and Hospital, Aurangabad. Dr. Yogita Dwivedi, she is MBBS MD Anesthesia, Associate Professor of Anesthesia and Critical Care, SNMC Agra UP. And Dr. Mahesh Sinha, he is Director of Academics, Ramakrishnan Care Hospital, Raipur, Central Zone, ISCCM elected member. Now, without losing much time, I would like to request our eminent chairperson, Dr. Mahesh Sinha, to take over the session and introduce our first speaker, Dr. Mitch Levy. Over to you, sir. I think Dr. Mahesh Sinha's mic is off. So, Dr. Yogita Dwivedi, please take over the session and introduce our speaker, Dr. Mitch Levy. Sir, you are not audible. Dr. Mahesh, sir.
Hello.
Sir, your voice is not.
Yeah, can you hear me?
No, sir. It's not clear.
Hello. Now?
Yes, sir, it's fine.
Hello. Can go ahead with the speaker.
Check audio, please.
Can't hear anything.
Almost nearly normal, greater than 50. A low shunt fraction, and remember, traditional ARDS is characterized by a very high shunt fraction, that is perfusion past alveolar units that are not ventilated. Loss of regulation of perfusion and hypoxic vasoconstriction. phenotypes, Hello, everyone. It's my pleasure to give you this brief talk on high versus low compliance. Is it a slogan or is it the right science? I'm going to try to do this in 12 minutes, so here we go. Much of this argument of high versus low compliance was hypothesized by Luciano Gattinone, who we all know and have tremendous respect for. This was initially published as an editorial in Intensive Care Medicine in June of 2020, early on in the pandemic. This is a quote from the editorial that based on detailed observation of several cases, we hypothesized. And what he hypothesized was two separate phenotypes, a type L phenotype, which he hypothesized was early on, which is characterized by high compliance, almost nearly normal, greater than 50, a low shunt fraction. And remember, traditional ARDS is characterized by a very high shunt fraction, that is perfusion past alveolar units that are not ventilated, loss of regulation of perfusion and hypoxic vasoconstriction, and something that we would all agree is characterized as a pulmonary vascular injury. In addition, this type L phenotypes in patients who die traditionally have a low lung weight and low recruitability. That's very, and as this is a combination of negative inspiratory intrathoracic pressure and increased lung permeability due to inflammation, which taken together leads to patient self-induced lung injury, or PSILI. That's as opposed to later on in COVID ARDS, the type H phenotype, which is characterized by more typical ARDS, low compliance, high shunt fraction, high lung weight, and high lung recruitability. So this is the typical ARDS pattern that we see pre-COVID. These are images from the editorial from intensive care medicine, and you see here a CT scan that was taken on a patient early on in their hospital course on day one, which really looks almost clear and is characterized by very low Hounsfield units and more typical of a clear chest CT, progressing to day 7 of looking more typical ARDS with a lot of dependent edema and compression atelectasis in the lower lung zones and a much more dense Hounsfield unit pattern, more typical of classic ARDS. So what is the pathophysiology of PSILI? And the key here is understanding that lung injury in particular is governed by transpulmonary pressure. And so you see here, and this is from a New England Journal article by Art Slutsky, and what it demonstrates very nicely, the transpulmonary pressure. Each panel is the transpulmonary pressure is down at the bottom. And you see here in normal spontaneously breathing patients at end inspiration, you have a transpulmonary pressure of only 8 centimeters of water. In a normal anesthetized paralyzed patient on mechanical ventilation at end inspiration, you have a transpulmonary pressure also of 8 centimeters. And a lot of it has to do with the difference in alveolar pressure minus pleural pressure. So in this case, you have an alveolar pressure of essentially 0 at end inspiration, where you have a pleural pressure of -8 for a total transpulmonary pressure of 8, similar to that in a normal anesthetized paralyzed patient on mechanical ventilation. Here in panel C, you see a patient with stiff chest wall on mechanical ventilation, again at the end of inspiration, a very high alveolar pressure of 30 centimeters, but also an equally high pleural pressure because of the stiffness of the chest wall. So still, the transpulmonary pressure is only 5 centimeters of water. Here you have a trumpet player while playing a note with a very high alveolar pressure, but also a very high pleural pressure because of the Valsalva movement of blowing a note. So still only a transpulmonary pressure of 10 centimeters. Contrast all of these 4 panels with a patient with marked respiratory distress on non-invasive ventilation at the end of inspiration, and you see an alveolar pressure of only 10, but a pleural pressure of 15 because of their wide intrathoracic swing on non-invasive ventilation at the end of inspiration. So here you have a transpulmonary pressure of 25 compared to 8, 5, and only 10. So you have a threefold increase in transpulmonary pressure in a patient with marked respiratory distress on non-invasive ventilation at the end of inspiration. And of course, this is the setup for lung injury that's induced by the patient because of wide intrathoracic pressure swings and a markedly negative pleural pressure because of the spontaneous breathing. And this here is the setup for patient self-induced lung injury. On the other hand, and so what I've tried to show you is the logic and physiology behind what Luciano hypothesized as the type L phenotype and the injury associated with that. But here's another study also, by the way, by Luciano. And here you see patients who are matched, ARDS patients, matched by PF ratio, then COVID ARDS patients, and patients who are compliance matched. So now you see this is the respiratory system compliance. And you see here in the COVID ARDS, yes, there's a higher, it's matched by PF ratio, and there's higher compliance in the COVID ARDS. But when it's matched by compliance, you see that the compliance, the more traditional ARDS patients have a much higher compliance when it's matched by compliance. So whereas the COVID ARDS have a much lower compliance when it's matched by compliance compared to traditional. And the same thing with non-aerated tissue fraction in a PF-matched ARDS versus compliance-matched ARDS. You see here that there's a higher non-aerated tissue fraction, where in COVID ARDS, there's not that much difference in the non-aerated tissue fraction. So these are data, and these are data that really argue against the hypothesis by Luciano. This is a group from, and here you see also arguing against the hypothesis from Luciano that basically you see here a more normal distribution of compliance in COVID ARDS. You see here, and this is a compliance of less than 35, compliance of higher than 35. And you see, interestingly enough, although there's a difference in the PF ratio, it's not statistically significant, and it's really 123 versus 132. There's no difference in the tidal volume between the low compliance and the high compliance patients. And by the way, these are 372 patients as opposed to the few case studies that Luciano used for his original hypothesis. And there's really no difference, although statistically significant. Most of us would argue that there's not much difference between 12 and 11.1. And the plateau pressure, clearly in the low compliance, the plateau pressure is higher compared to the higher compliance, as is the driving pressure, which is much higher in the low compliance patients versus the high compliance. Again, significant, statistically significant. But if you now look at the mortality rate in those patients, if you look at the mortality rate in those patients, you see, you see here, looking at alive at day 14, there's no difference in mortality at 14 days between the low compliance and the high compliance state. There is a difference in the mortality in the high compliance state, where there's higher mortality, and that's a 0.03 difference. There's a higher mortality in the 186 patients with higher compliance, and yet there is no real difference in PEEP. So this argues against Luciano saying that the high PEEP is not appropriate in the high compliance patients, and yet here the mortality is higher, even though the PEEP is not all that different between 11.1 and 12. And this again is the Belgian group that reported this. Here you see the effect. This was published in Critical Care Medicine in 2020. This is also an Italian group. And you see here, this is the difference in static compliance. Although statistically significant difference, you can see COVID versus classic ARDS. Both groups are lower than 50. So this is more in the 37 range versus the 28 or so range. So although statistically significant and different, both would be considered low compliance. And if you look at the lung weight, there was no difference in the patients with COVID ARDS versus classic ARDS, again, in opposition to what Luciano suggested, where these patients had a much higher, a lower lung weight in the type L group. So just reminding us that what Luciano emphasizes a lot is the baby lung. And so here we have the lung, the lack of homogeneity that's classic in ARDS that leads to over-distension of the so-called baby lung. And Luciano has pointed that out considerably, where you have the healthy lung in both COVID and in non-COVID ARDS, and a lot of the positive pressure during mechanical ventilation going to the relatively spared baby lung compared to the atelectanic lung. So, so does PCILI exist, and do the LNH phenotypes really exist? Well, I will say, and you've all seen these, these are 3 editorials in the same issue recently in Intensive Care Medicine, one by Art Slutsky and Marco Ranieri, another one by Luciano, where he took issue with the data, the presentation and editorial by Marco Ranieri and Art Slutsky. And then finally, equally interesting in the same issue from Martin Tobin, who argued against the atypicality of ARDS and COVID-19 and felt that it was actually a distraction for the bedside doctor. So for most of us, we can only pull out our hair and wonder, what is it? What really exists? And so the question is, are these phenotypes real? And are they chronologic? Do they represent different physiologic process? And is type H a result of PCILI, or is it just further progression of the pathophysiology of COVID-19? And ultimately, does it matter to the clinician? And that's probably the most important question, which is, are there 2 different phenotypes? Is there high versus low compliance? Is one the result? And how does it affect us? And that's what I want to end with, is what should we do as clinicians? Well, I've said this in a previous talk, and I'm going to say it again, which is trusting evidence-based medicine is really, really important. And we must individualize patient therapy. If a patient doesn't tolerate awake proning, higher PEEP, or spontaneous ventilation, it doesn't matter whether it's an L or an H phenotype. If our patients don't tolerate this, then we simply shouldn't do it. If when we try to allow patients to breathe on their own, they develop tachypnea and very large tidal volume swings. And when we try to use high PEEP, they rapidly desaturate. And when we try to flip them on their belly when they're still awake and not mechanically ventilated, then we just simply shouldn't do it. And we should trust not just evidence-based, but we should trust our patients and their reaction to us. And so I think it's important for us to remember that we must apply what we understand about ARDS. And as Martin Tobin said, let's not be distracted by COVID-19. We should stick with low tidal volume strategy in a patient who's not tolerating spontaneous breathing. We should force low tidal volume, 6 cc's per kilogram. We should use higher PEEP when it works, when a patient responds with recruitment and higher oxygen saturations. We should try proning. We should do it repeatedly. And honestly, we should continue to prone patients until it stops working. And finally, we should use ECMO only as a last resort. So my sense is it's not really so much of whether there's an H, whether there's an L, an H phenotype, and whether P-Cili really induces or leads to the H phenotype as opposed to the pathophysiology. I think we have to trust evidence-based medicine, tailor our therapy to what our patients respond to, and treat them accordingly. And with that, I'll say thank you very much.
Thank you, sir. Now, I would like to request our next eminent chairperson, Dr. Yogita Dwivedi, to introduce our next speaker, Dr. Harjeet Singh Dumra.
Good afternoon, everyone. Am I audible?
Yes, ma'am.
Yes, I'd like to welcome Dr. Harjeet Dumra. Sir is a consultant, pulmonary and critical care in Sterling Hospitals, Ahmedabad, and Chief Infection Control Committee at MediSurg Hospital, Ahmedabad. And in special mention, he's a national and international faculty and has delivered talks on various topics across the country. Welcome, sir. Kindly start.
As we come to terms with the significant morbidity and mortality associated with acute COVID-19, we've come to realize that a significant proportion of our patients who have survived have been left with devastating sequelae. Although post-COVID sequelae is a multi-system disease, specifically post-COVID lung disease is the one associated with maximum disability affecting quality of lives of our patients. In fact, those of us who believed that the pandemic is going to get over this year have now come to realize that the actual pandemic of post-COVID sequelae is just beginning. And hence it is extremely relevant that we discuss this topic of post-COVID lung disease as a part of trying to look at finer details of management of this particular condition. So let's look at the timelines and the definitions of long COVID. As all of you know, the first 4 weeks are related to either viral replication or as a part of hyperinflammatory response starting somewhere around the 2nd week. It could end up persisting up to the 4th week. So acute COVID is usually defined by signs and symptoms up to 4 weeks. In fact, signs and symptoms of COVID-19 from 4 weeks onwards are labeled as ongoing symptomatic COVID-19. Post-COVID-19 syndrome is defined as signs and symptoms that develop during or after an infection, which is consistent with COVID-19, which continues for more than 10 weeks and is not explained by an alternative diagnosis. In fact, these late sequelae of infection are attributable either to an inflammatory or viral host response that occurs approximately 4 weeks after the initial infection and can continue for as yet an uncharacterized duration. One of the important aspects of this particular post-COVID sequelae is that we used to believe that only patients who had moderate and severe disease, who were hospitalized or who were in the ICU would end up developing post-COVID sequelae. Here we are sadly mistaken, and even patients with milder disease who were treated at home sometimes can end up developing long-term sequelae. A simpler way of looking at it would be any patient who has had symptoms from 4 weeks to 12 weeks could be labeled as subacute COVID, or patients who have symptoms beyond 12 weeks up to 6 months to a year could be labeled as chronic post-COVID. So the terminologies would vary depending on which paper you read. Now, as I mentioned, post-COVID is a multi-system disease and it can affect any organ of the body. It could be associated with general symptoms like fatigue, muscular weakness, joint pains. It could be associated with neurological sequelae like anxiety, depression, sleep disturbance, post-traumatic stress disorder, cognitive disturbances, headaches, so on and so forth. It could be cardiovascular symptoms in the form of palpitations, chest pains, and signs and symptoms of thromboembolism, or it could be the form of renal derangements. But the most important is the respiratory sequelae, which manifest by breathlessness, cough, and persistent oxygen requirement. Please bear in mind that here we need to be very sure that we are not dealing with ongoing symptoms of COVID, and they are definitely post-COVID symptoms. And although sometimes this defining line is difficult to interpret, but most often, once you cross the 4-week barrier, the viral replication is by and large ended, and it is possibly that you are dealing with the post-COVID syndrome. So as I mentioned in my first slide, that we are dealing with this hidden pandemic, which we didn't realize would emerge once the acute COVID pandemic had subsided. In fact, studies have indicated that 90% of COVID patients experience COVID sequelae. At 9 months following hospitalization, 30% of the patients experience at least some COVID sequelae, and further observation has not shown regression in this number of sequelae. The majority of the population is left with residual lung disease, and nearly a third, that is 10% of all patients who have post-COVID sequelae, show pronounced fibrotic lung damage. In fact, the rate of complete recovery from lung damage is around 50% at 6 months and around 75% at 9 months. And beyond 9 months, there is very little scope for recovery, indicating that a large amount of patients would be left with substantial residual lung deficits. So what do we label this post-COVID sequelae as? The more literature you go through, the more kind of names you would encounter. So these post-COVID lung sequelae can be labeled as interstitial lung disease, diffuse parenchymal lung disease, pulmonary fibrosis, or fibrotic lung disease. What are we defining? Basically, we are defining as persistent changes identified on follow-up CT scans, such as architectural distortion, organization, parenchymal bands, ground glass and reticular opacities, traction bronchiectasis, and honeycombing. Plus, they should be associated with functional impairment. This is what constitutes a post-COVID lung disease. Apart from this, it is very relevant that you understand why we need to identify this post-COVID lung disease, because simply it is associated with extreme morbidity, long-term disability, and sometimes it can lead to progressive fibrosis, which can eventually lead to death of the patient. So what are the common risk factors associated with post-COVID lung disease? What are the mechanisms? How does it progress? And are there any treatments available to us? This is what we'll cover in the next few slides. So would all patients of post-COVID lung disease develop what we call as pulmonary fibrosis? Well, there are definitely certain pointers as to which patients might end up having significant residual lung deficit or progressive lung damage. So this could be divided into risk factors prior to the infection, like patients with male gender, elderly people, patients who have been smoking all their lives, particularly because it impairs healing process, patients with comorbidities like diabetes, underlying chronic lung disease, and cardiovascular disease. Some risk factors are related to the severity of the ongoing infection. This is manifested by excessive use of patients needing high flow oxygen, patients needing artificial respiratory support in the form of non-invasive high flow nasal cannulas or mechanical ventilation, presence of ARDS, persistent hypoxemia, and the cytokine storm. All of that indicate higher severity of infection, leading to increasing chances of post-COVID lung damage. Is there any way we could predict which patients with COVID-19 would progress to significant fibrosis at the end of 3 to 6 months? Unfortunately, there is no conclusive answer to this. There have been several studies which have looked at C-reactive proteins, IL-6, LDH, and D-dimer levels, and they have found some correlation between acute disease and long-term sequelae. However, the jury is still out on this, and we still do not have an accurate predictive biomarker which could identify these groups of patients. There are other markers which have been looked at: decrease in lymphocyte count, low plasma levels of interferon gamma, and shorter leukocyte telomere length. But again, this is still not conclusive. So what is the pathophysiology of post-COVID lung disease? Well, first and foremost, it is multifactorial. It is not fully understood and needs to be further investigated. Once a patient develops COVID-19 infection, most of these patients with mild to moderate disease would improve within 1 to 2 weeks. A small percentage of these patients would end up developing a cytokine storm, which is manifested by high CRP, increasing D-dimers, and increasing interleukins. This cytokine storm plays havoc with multiple systems in the body, but predominantly affects the lung. So in the lung, this is manifested by increasing hyaline membrane deposition, microvascular damage, and endothelial dysfunction. Now, as the cytokine storm subsides, the reparative or the regenerative process starts. And this is manifested by regeneration of alveolar epithelium, recruitment of fibroblasts, which eventually lead to extracellular matrix deposition. In most cases, this should be a proportionate response to the inciting trigger. However, in COVID, what we've seen is that COVID-19 infection specifically leads to binding with ACE2 receptors, and it activates the renin-angiotensin system, both of which lead to dysregulation of this healing process. In fact, we have found that in patients, there is reduction in protective antifibrotic, anti-inflammatory, and antioxidant systems. Besides this, the presence of ARDS, the use of mechanical ventilation leading to ventilator-induced lung injury, oxygen toxicity, and bacterial superinfection compound this damage, leading to further delay or impairment of healing. Ultimately, this leads to persistence of fibroblasts in the lung tissue, which leads to multiplication and deposition of collagen in the interstitium, ultimately leading to persistent or progressive pulmonary fibrosis. So what is the clinical course of these patients? The clinical course is basically dictated by imaging abnormalities and pulmonary function test abnormalities. And as you can see, these would be prognostic because a higher severity score on imaging or a very low pulmonary function score would obviously indicate significant damage, residual deficit, and significant impairment in quality of life. So this was a systemic review published very recently, which looked at the radiological changes over a period of 3 months and pulmonary function tests over a period of 3 months. It included around 60 studies, came out very recently. So at the end of 3 months, around 50% of the patients followed up on CT scan showed inflammatory changes. Around 30% of patients showed fibrotic changes. Although inflammatory changes reduced compared with CTs performed during hospitalization, there was no significant resolution as far as fibrotic changes were concerned. On the PFTs, around 17% patients were found with low FVCs, and around 40% of patients showed significant impairment of diffusion, indicating a significant residual deficit at 3 months post-COVID. The million-dollar question is, are these changes that we see on CT scan are likely to persist? Would they improve, or would they worsen with the passage of time? No doubt, because this has implications on treatment as well as prognosis. So what are the common changes we've seen in acute COVID? The commonest ones are ground glass opacities, reticulations, consolidations, and crazy paying pattern. However, in the post-COVID scenario, CT scans commonly shown architectural distortion with parenchymal band traction, bronchiectasis, mainly traction bronchiectasis. Ground glass opacities can occasionally be seen even by the end of 4th week, mosaic attenuation, and honeycombing, which is a marker of irreversible damage. So let's look at a couple of slides regarding these scans. So I'm showing you scans at 3-month intervals, patients who were admitted and then 3 months post-discharge. In some patients, you would have ground glass opacities usually associated with reticulations and organization pattern at 4 months. We believe that ground glass opacities usually would resolve with time, but occasionally there have been patient scenarios where ground glass opacities have progressed to fibrosis as well. But in most case scenarios, they should resolve with time. What about the organizing pneumonia pattern? This is at baseline, this is at 3 months. As you can see, the organization has resolved at 3 months, and in most case scenarios, this should be the case in post-COVID sequelae. What about changes of ILD? There are several manifestations of ILD on the CT scan, particularly with ground glass opacification, reticular abnormalities, and traction bronchiectasis. We believe that these changes are still reversible and should improve with time. Parenchymal bands, which are subpleural, likely represent focal atelectasis or scarring rather than diffuse fibrosis. Reticular abnormalities and interlobal septal thickening without or evidence of fibrosis may reflect inflammatory interstitial thickening, hence they are bound to be reversible. However, changes of traction bronchiectasis, bronchiolectasis, and honeycombing, these are the changes which usually indicate severe damage, they usually indicate irreversible damage, and these are the patients which most likely would be left with substantial post-COVID sequelae, and some of them can also have progressive lung fibrosis. So this is the one kind of scenario which you need to look out, because here is where pharmacological intervention might help. Besides ILD, you could also have changes of obstructive airway disease coming up in post-COVID scenarios, particularly like new onset emphysema, cysts, and mosaic attenuation. And in some patients, you would have residual chronic thromboembolic disease, or you can also develop thromboemboli even after 4 weeks, because this is the stage where patients are possibly immobile, they are not in rehabilitation phase, and the hypercoagulable state persists. So if I'm going to summarize my changes on the CT and what they usually evolve into, ground glass opacities should usually resolve. Organizing pneumonia in most case scenarios should also resolve. Reticular abnormalities, subpleural bands, and interlobal septal thickening we believe should resolve. However, traction bronchiectasis, honeycombing, and architectural distortion may persist or progress. So coming on to treatment, there are mainly 3 different phenotypes we are seeing in the clinics. The first one is patients with substantial radiological and lung function abnormalities who are symptomatic. And then there are 2 others where we see out of proportion either symptomatology or lung involvement. What I mean by that is some patients might have significant lung involvement in imaging but will have very few symptoms. And there are others who have significant lung involvement but very few symptoms. So what is the natural history of post-COVID fibrosis? Most of these patients, as I just mentioned, should improve with time. Some of them would remain static, which is less common, and very few of them would end up having progressive fibrosis. Now, there is still an active discussion about what should be the treatment in which group of patients. Until date, the efficacy, subgroup of patients who would benefit from therapy, timing for initiation of treatment, and the safety profile of treatment have not yet been determined. So currently, there are no fully proven therapeutic options for post-COVID lung disease. There are several trials looking at several different drugs. This includes steroids, antifibrotics, so on and so forth. And maybe in the next few months, we'll have some positive data coming from these trials. Till then, I'm just going to highlight a few studies which have looked at treatment aspects of post-COVID lung disease. This, published in the Annals of American Thoracic Surgery very recently, looked at 30 patients who were discharged and were identified with persistent interstitial lung disease with non-improving symptoms. And they were offered low-dose steroids, 0.5 milligrams per kg body weight, 2 months after discharge for around 3 to 4 weeks. These are patients, 50% of them were in the ICU, around 45% needed invasive mechanical ventilation. They were significantly disabled, as you can see, with their 6-minute walk distances. Around 50% of predicted FVCs were maintained, but DLCOs were quite low. As you can see, after treatment, there was a significant improvement in the DLCO and marginal improvement in the FVCs as well, clearly indicating that treatment with corticosteroids was well tolerated and associated with rapid and significant improvement. So which are the patients whom you should consider for longer period of steroids? Exactly, very difficult to define, still a gray zone, but primarily you could use them in patients with radiological features compatible with organizing pneumonia, mainly in the presence of hypoxemia at rest or during exercises. Please bear in mind, you end up using lower dose of steroids, 0.5 to 1 milligram, because higher dose would lead to myopathies or hyperglycemia, which would continue to impair healing process and would affect mobility of these patients. How long should they be given? Maybe a trial of 4 to 6 weeks, because that is the time we anticipate the inflammation should subside. What about antifibrotic? And that is, again, a huge debate. Well, the exact role of antifibrotics is still not clear. However, there is a clear rationale for their potential usefulness. We have been using these products in IPF, and there is a many common demographic factors between COVID and IPF. We've used these drugs to prevent acute exacerbations in IPF, and COVID is just like an acute exacerbations, which is manifested by fibroblast and honeycombing. And hence, maybe antifibrotics may have a role to play in these settings. You could use either pirfenidone or nintedanib. So which are the groups of patients where you would try these drugs on? Most likely you should never use them in patients who are spontaneously improving. However, How would you identify which patient is going to progress upfront? Progression is extremely difficult to ascertain, and it can only be apparent over time. And hence, identifying these groups of patients who would benefit is an extremely challenging task. We would love to have an accurate predictive biomarker, but that is still not available. When should you start these drugs? Most of these drugs take 4 to 12 weeks to take effect, and hence it would be quite late if you start. Hence, it would not be effective if you start late. Also, most of these drugs are utilized to prevent progression rather than treat fibrosis, because the trials which were done in IPF patients only showed slowing in the rate of decline in FVC. They did not show arresting of fibrosis or improvement in fibrosis, and hence antifibrotics should best be used to prevent and hence be used early. So which time frames can you use these drugs? You could either use them in ICU patients which have high oxygen requirement and need some kind of respiratory support, or on follow-up, that is post-discharge, you could use them in patients who have slow, delayed resolution or who are showing progression. So mostly these drugs should be started by the 3rd or maybe the beginning of the 4th week of illness. So what could be the possible indications to spell them out? If you are going to use them in the hospital, that is in the ICU, we are going to look at patients who have high risk of progression to post-COVID lung disease. These are some of the risk factors which I have already enumerated. You could use them in patients with fibroproliferative phase of moderate to severe ARDS, or patients who have a CT scan evidence of fibrosis, traction bronchiectasis, and or honeycomb. You could also use them post-discharge when the patients come for follow-up, particularly in patients who demonstrate an evidence of progression, which means a decline of at least 10% in the FVC and increase in the extent of interstitial lung abnormalities. For patients who have persistent and non-progressive pulmonary lesions, but are significantly disabled or hypoxemic or show significant functional impairment, you will have to individualize therapy. So I would not advocate using it for all of those groups of patients. In some group of patients, you might end up needing combination therapy, that is a therapy which combines antifibrotic with steroids, because a lot of us believe that there is still an ongoing inflammation way beyond 4 weeks in a small subset of patients. Patients might also be left with obstructive lung disease sequelae, and these patients can be treated with inhaled steroids. Particularly patients with persistent cough might benefit from inhaled steroids. So just to summarize what I have mentioned about treatments, I have shown this slide before. So patients with organizing pneumonia, which beyond a point persists and the patient is possibly hypoxemic and does not seem to be improving, steroids could be an option. For reticular abnormalities, interlobular septal thickenings and subpulmonary bands, again, steroids might be a good option. However, for patients with signs of irreversible damage in the form of traction bronchiectasis, bronchiolectasis, and honeycombing, antifibrotics or a combination of steroids plus antifibrotics might be useful. What about the other treatment options? Oxygen support for all patients discharged at home with hypoxemia till they achieve a baseline saturation of 92% with the on-room air. Pulmonary rehab for all patients who are disabled and are not ambulatory at discharge is integral to improving the quality of life of these patients. A large group of these patients continue to be immobile when they are discharged. They are still hypercoagulable, and hence they can develop thromboembolic complications even after discharge, and hence prolonged duration of anticoagulation might be required in some of these patients. Prevention of secondary infections in a compromised lung is important to prevent further delay in the healing process, and hence vaccination with pneumococcal vaccines and influenza vaccines is mandatory. Some of these patients who do not respond to any form of therapy might be candidates for lung transplantation, and some lung transplants have been done in these groups of patients even in our country. Although the jury is still out as to what would be the best time or what would be the best kind of patient who should be taken up for lung transplant. Some of the concerns are, like I said, what is the timing? How do you define end-stage lung disease? They should be negative virologically before we perform a transplant. What about the protection of the transplant team? What about immunosuppressive therapy post-transplants, and how would it have a bearing on the compromised body of a post-COVID patient? How would you prevent recurrence of COVID-19 in the allograft, although we have not had any evidences till date in the few transplants we have done? And what would be the clinical course of these recipients? Hence, the jury, like I said, is still out as to whether lung transplant should be advocated in quite a few of these patients with significant lung damage. To end my talk, I have shown you that post-COVID lung disease is a significant impairment in quality of life in quite a few of our patients who are left with post-COVID sequelae. Although post-COVID sequelae is a multi-system disease and can affect the heart, the kidneys, the bloodstream, it can have neuropsychiatric symptoms. Amongst them, post-COVID lung disease is the one which is most disabling. Hence, although patients who are spontaneously resolving might not need any kind of therapy, but patients who have dyspnea and persistent hypoxemia should be followed up serially, and they should be subjected to serial 6-minute walks, pulmonary function tests, and imaging and echocardiogram investigations at 3 and 6 month intervals. Those patients who do not show improvement, are persistently hypoxemic, or show progression in their disease are candidates for therapy, and you have an option of choosing steroids, antifibrotics, or a combination of the two. Last but not the least, holistic and wholesome management is mandatory to improving prognosis of these groups of patients. I thank you for a patient listening, and I'll be open to questions. Thank you.
Are there any questions from anyone?
Hello, I'm Dr. Nikal Jain. Hello, can I ask the question?
Yes, please go ahead.
Yeah, actually, one of the risk factor for post-COVID lung is oxygen therapy, probably high flow NIV and probably mechanical ventilation. So what are the targets of oxygen to prevent post-COVID lung syndrome, particularly about the oxygen saturation or PF ratios or PaO2? Can we have some targets so that we can prevent further lung damage in the recovery phase?
So generally speaking, there have been two groups of studies in the past about patients of ARDS. And previously we used to believe that targeting 88 or 89 in patients with moderate to severe ARDS would give you reasonably good results as far as oxygen toxicity goes. But of late, the latest trial showed that targeting a slightly higher saturation of maybe 89 to 92 would be a better option, because there was an increasing trend towards mortality in patients who were extremely hypoxic. So maybe to sort of keep a right balance, maybe 90 to 92 would be ideal. So anything above that is not needed.
And what about the pulmonary hypertension, which is again, I think, a reasonable cause of post-COVID lung disease?
So pulmonary hypertension in post-COVID lung disease is multifactorial. It could be a combination of the residual lung damage, which has happened as a part of parenchymal involvement, and it could be also associated with the thromboembolic phenomena, which has resulted in this kind of a situation. So prevention is basically the best way to do it would be to prevent onset of parenchymal lung disease beyond a point. So for that, like I said, timing of your drugs, steroids and antifibrotics should be optimized. And anticoagulation in these groups of patients who possibly are going to have prolonged bedridden state in the ICU and post-discharge should be prolonged to prevent thromboembolism. And if you document thromboembolism, obviously the dosages should be therapeutic.
Yeah, thank you.
Okay.
Thank you for a wonderful lecture on post-COVID.
Thank you. Thank you.
Thank you, sir. Now, I would like to request our next eminent chairperson, Dr. Anand Nikalje, to introduce our next speaker, Dr. Prashant Kumar.
Hello, everybody. I think this session is going quite well. And after two very important and informative lecture, I would like to introduce Dr. Prashant Kumar, who is a good friend of mine. He's a professor, Department of Anesthesia and Critical Care at PGIMS University of Health Sciences, Rohtak. And he's a master's in business administration, Commonwealth Fellowship in Neuroanesthesia, Neurocritical Care at Royal Victoria Hospital from UK. And he's postdoctoral fellowship in neuroanesthesia and CMC Vellore. So over to you, Dr. Prashant, for early versus late intubation in COVID ICU patients, a very important topic. Please, Dr. Prashant, you can go ahead.
Namaskar. I am Prashant Kumar, and a very important and interesting session on early versus late intubation for COVID-19, and we will be discussing it together for next couple of minutes. So I am Prashant Kumar, and I bring greetings from Pandit Bhagwat Dayal Sharma University of Health Sciences, Rohtak, India. Now, the pathophysiology of COVID-19 remains unclear and distributive between the respiratory and lung getting involved, mucosa getting involved, or the vascular part getting involved, and autoimmune parts. But the main manifestation remains acute hypoxemic respiratory failure, and for which the patients require respiratory support. And it is somewhat similar to acute lung injury presenting with respiratory failure, and when severe enough, it is placed in the category of acute respiratory distress syndrome, or ARDS. Now, when we look in the ARDS, the timing of intubation was associated with clinical outcomes, and ARDS patients undergoing late intubation had markedly higher mortality rate compared to those who were intubated early in the course of disease. Similarly, the Surviving Sepsis Campaign panel also recommended the management of mechanically ventilated patients with COVID-19 should be on the similar lines as other patients of acute respiratory failure in ICU. For the septic patients, the timing of intubation was studied in length, and many studies have proposed the factors which are responsible to determine timing of intubation, and they can be divided into 3 domains of practice depending on patient factor, clinician factor, and system factor, which we all work in. And very clearly, the patient factor about the nature and acute illness, comorbidities, clinical presentation, and a background of clinician and training of clinician, experience of clinician, and for the system, workload policies, protocols, hierarchy, they always remain important for all types of patients going into respiratory failure. Depending on that, we can look for early intubation, which is elective part. We can plan, we can justify, and we can do it at our ease, while just in time is called the urgent one, where the patient starts decompensating and we do it. But whenever we fail to do that, we may end up in having late or rescue intubation for any types of patients with ARDS. Now, while most of the circumstances, these patients of COVID-19, they fit into the Burley definition of ARDS, but it has a distinctive feature that there are patients where hypoxemia is often associated with normal respiratory system compliance, and it was never seen in ARDS before. But plus severe hypoxemic patients of COVID-19, despite having a single etiology, they have varied spectrum ranging from asymptomatic infection to ARDS or even death. And whenever symptomatic, there may be a normal breathing patient, silent hypoxemic, or patient with significant dyspnea. There can be hypocapnic or hyper or normocapnic patients. So looking for these criteria, we need to look for need for intubation in COVID-19, which is despite most of the patients being managed with supplemental oxygen therapy, few with the severe respiratory failure require intubation, as the tracheal tube placement allow us to regulate oxygen, pressure, and volume, and also it stabilizes the airway. Looking for the early or late intubation, in ARDS patients, septic patients, higher mortality has been reported when we delay the intubation, but ideal time of commencing the invasive mechanical ventilation in COVID-19 remains unspecified, and we are still debating that. But frequent respiratory decompensation after initial phase of stability causing deterioration rapidly, and that makes the process of intubation an emergency call, which in presence of all the PPE kits and restricted movement in the ICU becomes challenge. Because of that, the experts from China, Europe, United States, all over the globe have supported the strategy to intubate patients early so that the emergency things are reduced. As the data started coming in, a multi-center retrospective study from Korea of 23 patients intubated on day of meeting criteria of ARDS and 24 not being intubated on day. It is important to see that out of 24, 8 patients were never intubated, and the results were saying that there was similar in outcome in the patients of early versus late intubation. Now, points favoring the early intubation remain to reduce subsequent possible aerosolization of the virus, like we are using FNAC, high flows, and all these cause aerosolization. And in spontaneously breathing patients, early intubation also prevent self-inflicted lung injury. But points in favor of late intubation, they go that the intubation itself may generate viral aerosols, and we can avoid complications of airway trauma, ventilated associated pneumonia, and avoid complications of sedation and everything requiring there. Now, in a very good effort from Dr. Gattinoni about studying the different patterns of COVID-19 patients coming to their emergency, depending on the infection severity, ventilatory responsiveness of the patient to hypoxemia, and time relapse between the onset of disease and reporting to hospitals. These patients were divided into two phenotypes of type L and type H. And what these type L and type H patients look like, that the type L patients had low elastance and falsely called as high compliance, and low ventilation to perfusion ratio, low lung weight, and low recruitability, while type H patients had high elastance, high right to left shunt, they had high lung weight, which can be seen with the CT scan, and they had high recruitability. Now, depending on these two phenotypes, the treatment advice is that the increase in FiO2 type L patients respond well, and type L patients can be given with several non-invasive options of FHNC, CPAP, and NIV, while pleural pressure swings can be measured with the esophageal pressure swing, which if going above 15 centimeter of water, risk of lung injury increases and therefore should be intubated. And once intubated, we should look for type H patients should be treated as severe ARDS, including high PEEP as tolerated for hemodynamics, prone position, and extracorporeal support. But we need to accept that there is a large spectrum of involvement of lung and different characteristics of patients, which always have overlap. In a very large systemic review and meta-analysis of 12 studies, nearly 9,000 patients, there was no statistical significance between all causes of mortality for COVID-19 patients, where early versus late intubation were looked for. And many survivors were non-intubated, and many never required intubation and early mechanical ventilation. One clinical parameter which has been studied and is gaining interestingly importance is the ROX index, which is the ratio of SpO2, FiO2, and respiratory rate. And it was studied and found to be interestingly important for the need of intubation in patients of hypoxic respiratory failure. The similar can get translated for COVID-19 for early identification, because the need for adherence of airborne precautions and personal protective equipments for the staff involved, it is difficult to deal with the cases where the quick event of deterioration happens, and these emergency intubation may risk the infection to healthcare providers. So in case it is suddenly deteriorating, it becomes difficult. So the decision of timing of intubation should be applied in the clinical practice model identified for clinically critically ill patients of COVID-19 for their respiratory deterioration. And also appropriate use of various oxygen therapy techniques, including high flow cannula, NIV, should be considered and correlated with clinical patient before directly jumping to intubation. And deciding optimal time of every patient is an art, and it should be taken not only on the time rather than chronology of symptom, duration of illness, respiratory rate, disease severity as looked by the oxygen impairment, lung infiltration looked by the CT scan, and use of objective criteria like ROX index to determine the group of patients who are at risk, and they should be giving the intubation at the right time. Thank you very much for listening, and we are still learning. Thank you very much.
डालना वो मीटिंग आईडी W4 कैपिटल
कॉल करो कर दिया सर कॉल उठा रहे हैं हेलो हाँ सर वो होस्ट साइट से परमिशन चाहिए वीडियो के लिए
हेलो
ओके
Are there any questions from anyone?
Can I ask question to Dr. Prashant Kumar?
Sir, please.
Yeah, Prashant, it was a wonderful lecture, and I think it's the most controversial topic of when to intubate a patient of COVID ARDS. So can I take home message that yesterday Dr. Dhruv said everything has changed and nothing has changed. So before COVID should be the norm of intubating the patient in COVID ARDS. What is your take on it?
As I put in my last summary slide, that time cannot be guided for guiding the intubation for any patient. It would be clinical picture, radiological picture, and the system in which we work that we should be looking for. Objective index might be ROX index or Berlin's criteria, and those things should be very closely monitored in terms of intubation for a patient in COVID, because the problem in the COVID patient is not the time, but the timing which makes it the emergency situation, and that makes the patient and every system to collapse.
Right. I think manpower was a big issue in getting patient intubated right time, and secondary infection was, I think, a major, a drawback which caused more problems in our intubated patient. But I think rather we should have a topic on when to stop non-invasive ventilation and how long to continue non-invasive ventilation in addition to your yeah, it was a wonderful lecture. Thank you, Prashant.
Thank you, everyone.
Thank you. Good afternoon to everyone. Now we have a wonderful. Audible? A thematic session, and the first speaker is Dr. Suresh Ramaswamy. He is a senior consultant pulmonary and critical care medicine Apollo Glenlee's Hospital, Calcutta, and he will discuss the transition from ventilation to ECMO. Now I request to Dr. Suresh. Dr. Suresh.
Hello everyone, and it's a pleasure to be here speaking on the W4C on the topic given to me, the transition from ventilation to ECMO. Let me just put this on slideshow. Right. We know that respiratory failure requiring mechanical ventilation is very common, and this has been very much more pronounced with the COVID epidemic. And with the complications of mechanical ventilations, better strategies have always been thought of, and extracorporeal life support is the application of technology to sustain a life beyond a critical stage of illness when the cardiorespiratory system is ineffective. So by definition, ECMO occurs or situated outside the body. It's an extracorporeal life support, provides gas exchange via an extracorporeal support. It provides support to a failing lung, failing heart, or both. So the ECLS, that is extracorporeal life support, is of two types, ECMO and ECCO2R. ECMO can be veno-venous and veno-arterial. And most of the time when we talk about acute respiratory failure, and especially COVID, and especially the hypoxic respiratory failure in ARDS, we are talking predominantly about VV ECMO. So the extracorporeal membrane oxygenation, the ECMO term is is an overarching term for all forms of support. Whenever you use a blood pump, artificial lung and vascular access to get the blood out. But generally the term extracorporeal life support is preferred. Next, ECMO generally refers to the membrane oxygenation only, and VV ECMO is what veno-venous ECMO refers to the modality when we use for ARDS. All right. So in VV ECMO, blood is withdrawn from the venous system and then reinfused to the venous system. So that is why it's called veno-venous, and typically it will flow rates of 3 to 7 liters per minute. And this mode supports respiratory gas exchange only. It's not a hemodynamic support. The principle is that you remove the venous drain from the blood from the venous drain is removed, carbon dioxide is removed, oxygen is added through an extracorporeal device, and blood is returned to systemic circulation via another vein. And this is a graphic representation of the same, in the sense there is venous withdrawal from a cannula which is placed just at the right atrium, and the blood is deoxygenated, drawn into the pump by negative pressure. The pump expels the blood under positive pressure and drives it to the oxygenator. In this oxygenator, there's a room air, and oxygen is delivered in varying fractions to the inner core of these blunt hollow fibers where gas exchange occurs. Carbon dioxide comes out from the blood and goes in to these hollow fibers, and vice versa. Oxygen goes out from here and enters into the RBC, flowing through it, and then you return the blood by placing it in the right internal jugular vein at the right atrium. And so there is a mixing of blood that happens. And this is a very simple mechanism. As I said, the mechanism is based on the sweep flow, which I just showed to you. There are complications for it. So we need to be, it's not that very easy to put it on everybody. So there are neurological complications, especially bleeding can be there. Most important thing is bleeding from other sides, cannula side bleeding, surgical side bleeding. The hematological complications have decreased significantly, and the circuit related complications have decreased significantly. Because of the newer technology, the pumps are much better, and it's actually much better. The infections actually remain the big problem for us. For us, most of our patients who go on beyond 10-14 days of ECMO, it is bloodstream infections from either the cannula or from other venous access. That is a key to problem. So when we talk about putting somebody, transitioning somebody from ventilation to ECMO, we need to be aware of these situations as to what is happening. So ECMO, the concept of moving the heart-lung machine from the operating room to the ICU was first deployed in 1971. And there was a huge enthusiasm in the early part. However, there were 2 negative randomized trials in 1979 and 1994, which kind of put an end to the concept of ECMO for quite some time. The negative trial of 1994 by Morris et al. Randomized severe ARDS to 2 intervention, pressure control inverse ratio ventilation followed by veno-venous ECO2 or to conventional mechanical ventilation. The trial was stopped early for futility, no survival difference, there was significant bleeding groups, and unfortunately the technology in those days was different, and things have really moved forward subsequently. The inflection point by which they really have started looking at ECMO again was the H1N1 epidemic in 2009, and now to some extent the 2019 COVID epidemic. The publication of the CSER trial and the widespread use of ECMO during the H1N1 epidemic has led to these positive trials in this thing. And CSER trial was a positive trial. Let's put it in a way that definitely showed that I was a randomized trial assigned 180 patients with severe acute respiratory failure to a single ECMO center in the United Kingdom. The patients who came to the ECMO center had significantly increased survival without disability at 6 months compared to conventional management. The key here is that they were transferred to an ECMO center, not necessarily put on an ECMO. So that is what is important, is that you're sending to a center where the transition from mechanical ventilation to ECMO happens under expert supervision and after making sure that everything that can be corrected is corrected. So there is a huge difference. So the positivity, the benefit that patients got, referral and transfer to an ECMO center was associated with a significant lower hospital mortality, 23.7 versus 52.5%. So a single center with a huge experience in ECMO and management of ARDS will help you. So I think transitioning from, when we transition patient from mechanical ventilation to ECMO, sending to a high volume center may be the first thing that needs to be done. In the other reason why there's been a positive trend towards ECMO benefit in transition from ventilation to ECMO is that the is no longer just gas exchange. We want to minimize hypercapnia and minimize hypopnea, but you also want to minimize lung stress and strain, and most importantly, reduce the diaphragmatic myotrauma, and as a result of which you have better ventilator, decreased ventilator complication. But the most important thing is you put in an ultra lung protective strategy, as a result of which the lung stress and strain is decreased, your plateau pressures are decreased, your respiratory rates are decreased, your driving pressure is decreased, because we put them on a rate of 10, tidal volume of just 200 ml or 4 ml per kilogram, and so on and so forth. So all the villi, ventilator-induced lung injury complications, goes down. As a result of it, there is decreased MODS and there's a decreased mortality, and that's the purported reason. And minimizing hypoxia and hypercapnia is no longer the main benefit, but definitely minimizing hypercapnia is also important because it decreases the respiratory acidosis and just prevents the right ventricular failure that happens with prolonged hypercapnic ventilation, hypoxemic ventilation that happens in conventional ventilation. So the present indications of ECMOs are in very, very severe ARDS, moderate ARDS, lung transplant, bridge to lung transplant, so on and so forth. But my topic is to restrict myself to very severe ARDS when we transition patients from ventilation to ECMO. So the clinical evidence is the EOLIA trial now. The EOLIA trial was published in New England Journal of Medicine in 2018. It's an RCT of protocolized mechanical ventilation or ECMO, and 90% of controls and 66% of ECMO patient underwent prone positioning. So it's a standard of care that was doing. Again, the treatment was terminated for futility because non-statistically significantly large reduction in mortality with ECMO. There were 2 deaths attributable to ECMO, and that's why bleeding leading to transfusion occurs more frequently in the ECMO group. The overall rate of complication, however, was very, very low. And as I said, the previous generation of ECMO is now completely different, and it's the same. But if you look at the post-hoc Bayesian analysis of EOLIA, again, the probability of mortality is very high. Probability of a mortality benefit is high. The probability of an absolute reduction of 2% or more range from 78% to 98%. So this suggests that the mortality benefit to ECMO in very severe ARDS as defined by the EOLIA entry criteria. So there is a good reason, rationale to transition people from mechanical ventilation when they meet the indication as per the EOLIA criteria. So when do we transition? So you can use certain criteria, like if your predicted risk of mortality is 50% or greater, carbon dioxide retention, plateau pressure always greater than 30, and or pH less than 7.25. But the best one is the EOLIA criteria. So we transition patients when you require invasive ventilation for less than 7 days, you meet the criteria for ARDS, and you meet one of the following 3 criteria despite your best measures of ventilation, recruitment, proning, and you at the end of it, you are still on more than 0.80% of oxygen and peak of more than 10, and your PF ratio is less than 50 for more than 3 hours or less than 80 for more than 6 hours, or pH less than 7.25 with PaCO2 greater than 60 millimeter for greater than 6 hours, with maximum respiratory rate of 35, adjusted to a plateau pressure less than 32. So when you meet any one of these 3 criteria, that's when we say we need to transition you to an ECMO, and you might be a benefit. But again, the selection of patients has to be done very well, because it's though the evidence, the EOLIA trial does point to a mortality benefit, especially in this subset of very severe ARDS. but the cost, the resource intensity, and the ability to provide such care, especially during a pandemic, needs to be taken account. And so there are a number of prognostic systems which can which can help us to transition patient from mechanical ventilation to this thing. So this is the Italian ECMONET score, PRESERVE score, Marcel score, the German Center score, and so on. Again, these scoring systems have been limited due to small derivation cohorts, restriction to a very specific population, and lack of external validation. But the one thing which is being used a little bit is what is called as the RESP score, or the respiratory ECMO survival prediction score. This is derived from a large derivation cohort using data from the XFlow registry, and so it requires a few things like day 7, how many days of ventilation, age, immunocompromised, days of mechanical ventilation before, diagnosis group, acute associated infection, and all these things. And these are available, and we can do this. So these scores may be useful when it predicts an extremely high risk for short-term mortality. It suggests that if you have a very high mortality predicted with the REST score, you know that even putting them on an ECMO, they would have an extremely small chance of survival. Death is almost certain with or without ECMO. So these are the kind of things which help us in transitioning patients from an ECMO, from mechanical ventilation to ECMO. So using an Eolia and score, using a REST score to predict acute mortality, and understanding the financial and ethical implications. The ethical issues are there because, what do you do when patients don't get better and we are not a transplant center? How do you transport them? When do you withdraw? What happens if the oxygenator goes south after 3 weeks or 2 weeks of use? So there are a lot of issues, and financial issues are obviously huge. Obviously, the mortality in ECMO, I haven't put in the slide, the meeting in CHEST just today has found out that the mortality with ECMO during the second wave was about 69% as compared to 32% in the first wave using ECMO in a University of Philadelphia tertiary care center. So there is actually causing the question of, during a pandemic, is it possible even to, during waves, is it even possible to do ECMO? So there are issues. So there is no question that the extracorporeal life support for respiratory failure works. Does ECMO work? That need not be answered. It does work. But what we need to ask is, by how much does it work? In whom does it work? And at what cost does it work? So the transitioning that we do from mechanical ventilation to ECMO should answer this question. Is this patient going to be beneficial? Is this patient going to die irrespective of use of ECMO, and with or without ECMO by using a REST score? Does he meet the criteria for Eolia, criteria for being in transition to a ECMO? And is there a financial and ethical questions that have been answered? So once we do that, then I think we can transition them to ECMO from mechanical ventilation. Thank you very much for your kind attention. I hope I was able to finish in time.
Yeah, thank you so much, sir. Now, are there any questions? Anyone?
We are already delay time, so we move forward to our next speaker.
Okay. Now
next speaker is senior consultant in respiratory and critical and sleep medicine, Apollo Hospital, Ahmedabad. He is one of the organizers for coming 2020 conference critical care in Ahmedabad. He will speak on pulmonary embolism in COVID. Early identification is key. So please, Dr. Manoj Singh, it's mic to you.
Namaste, friends. Today I am here to speak on pulmonary embolism in COVID-19, whether early identification is the key. You all know that pulmonary embolism has been a great masquerader in critical care, and COVID-19 was no different. COVID-19 showed us that this was one of the most leading cause of illness, deterioration, and death. So if you see the incidence of pulmonary embolism in COVID-19, it was definitely way ahead than normal critical medical surgical patients. There are numerous publications on this. If we see the PubMed, almost close to 1250 results is what we see. The incidence of P in hospitalized patient has been reported to be around 9%. The retrospective nature of the reported cohorts in the relatively short periods may be underestimated the real incidence of P. But if we see in COVID-19, P can occur in almost 1/4 of the patients with admission criteria. So in a prospective observational trial of 150 patients in this trial published in Intensive Care Medicine from the France, the P occurred in 16% of patients despite thromboprophylaxis. So it was twice as high as frequency in patients admitted in non-COVID ICU. So this is very, very alarming. So here, the study published in Radiology 2020, which included 27 studies, 4 on non-ICU patients, 12 on ICU patients, 11 with both. So total 3,342 patients. Reported incidence of P and DVT was close to half of the patients who got the imaging had P. Pool incidence says that the DVT must be almost close to 16.5% patients. So author has 3 important points. Pool incidence in ICUs, as we discussed, 24 versus 10 in non-ICU patients. And incidence of COVID-19 ICU patients was almost 24 versus 13 in non-COVID ICU patients. And DVT was only present in 42% of patients diagnosed to have pulmonary embolism. So what do we see? 22% of patients were found to have pulmonary embolism. Patients with high BMI had 3 times more risk of developing pulmonary embolism. Patients on statin were less likely to develop pulmonary embolism. Increased D-dimer and CRP in conjunction with raised oxygen requirement may be a predictor of pulmonary embolism even when the patients are receiving blood thinners. That is important aspect. 72% of the PE patients who actually did not require ICU level care, suggesting that timely diagnosis and use of blood thinner could have played a very high role in treating process. Based on this study, early detection of PE could further enhance and optimize the treatment for patients present in the ED with COVID-19. So advise clinicians to think of PE as an additional complication early on during the admission of patients whose symptoms and lab point to that condition. So always have a high degree of suspicion. Routine thromboprophylaxis does not rule out P or VT. So closing your eyes isn't going to change anything. Nothing's going to disappear just because you can't see what's going on. In fact, things will be worse the next time you open your eyes. So what is the pathophysiology of PE in COVID-19? It's increasingly clear that critically ill patients with COVID-19 can develop a prothrombotic form of DIC, which places them at a dramatically increased risk of thrombosis. So these are the traditional risk criteria of PE, which all of you know. This is the classic Vercoe's triad, which actually increases the risk of pulmonary embolism. But in patients with COVID-19, we all know the cytokine storm, we all know hypoxia also increases independently blood viscosity, and there were high incidence of immune-mediated thrombi. So it was basically not an in situ embolic phenomena. Actually, it was an in situ thrombosis. So because we saw a lot of patients without DVT, we saw a high rate of peripheral PE, and we saw PE happening at where the lung parenchymal lesions were there. So that is how this is unique disease which has an in situ propensity of development of thrombosis rather than having a DVT and then developing an embolic phenomenon. When should we do CTPA? So not everyone you should undergo CTPA. A patient with COVID-19 should get a CTPA when there is a clinical indication. We are going to see that. So there are 2 criteria. One is in ICU. In ICU patient with worsened symptoms, PA should always be done if possible. Patients with a discordant picture, you see a patient where CT initially was reported to be okay, but he's not behaving normally. He's tachycardic, he's hypoxic, or he has rapid worsening. CTPA should be considered. And we have an Apollo criteria. Whenever the patient's D dimer was 6 times the upper limit of normal, we used to subject the patients to CTPA when they were worsening. So when objective imaging is not feasible, what do? You definitely rely on clinical assessment based on history, physical examination, and other tests. Observational data show that 7 to 40% of patients with COVID-19 who require mechanical ventilation will definitely have a DVT or PE happening in COVID-19. So those who are on ventilator, sudden need of ventilatory support, failing oxygenation, consider PE unless otherwise. Does a D dimer effectively rule out P or DVT, a normal value? Of course, yes. Definitely, a normal D dimer will provide a reasonable confidence that the DVT is not present. So at least if the D dimer is normal, you have to think about alternative causes of worsening of the patient. What about therapeutic implication? Diagnostic, we saw, yes, definitely you have to have a low threshold of developing low diagnostic armamentarium to diagnose PE. Accumulating evidence suggests that therapeutic change also definitely should be revisited. So the ISTH and the ASH have recently recommended that a prophylactic dose of LMWH or a subcutaneous unfractionated heparin of 5000 TID should be started in all patients of suspected or confirmed COVID-19 has admitted in the hospital. In patients with known hit, fondaparinux should be used. Although limited data are available, it is reasonable to consider pharmacological thromboprophylaxis in patients admitted to COVID-19 infection, even in pregnant women, since they are likely to have a high risk of VTE. In obese, higher weight-based doses should be considered rather than traditional. So if there is a patient who was needing hospital admission, always do a prophylaxis therapy from day 1 onwards. How should we manage COVID-19 patients who experience recurrent clotting from the device related like lines, ECMO, CRRT, despite prophylactic anticoagulation? And although it is of unproven benefit, it may be reasonable to increase the intensity of anticoagulation or switch to anticoagulants in these settings. Any decision to increase the intensity of anticoagulation should be taken in account with the bleeding risk of the said patient. So if those patients are at high risk, you feel that they are on lines and device, and already they have embolus or a thrombus seen on the CTPA, you can increase the prophylaxis or a treatment, but the bleeding risk should be discussed with the family. So should therapeutic or intermediate dose anticoagulation be empirically used? The answer is not clear, but the ASH says till the results of the ongoing trial are open, therapeutic or intermediate dose anticoagulation should not be considered in all patients. So it will be updating as when we have the rapid and the MPRCT trial published, we will be getting new data whether high dose or double dose in patients with a high risk will benefit them as compared to the bleeding risk is concerned. So till now, for patients requiring ICU critical care, ASS says prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation in who do not have suspected of confirmed VTE. They says guideline panel suggests that an individualized assessment for patients with risk of thrombosis and bleeding is important when deciding on anticoagulation therapy. Risk assessment models to estimate thrombotic and bleeding risk in patients are available, but still they are not validated as compared to non-COVID ICU patients. And what about patients when they are going home? Should they be routinely discharged on thromboprophylaxis? Patients hospitalized for any acute medical illness are at increased risk for at least 3 months, as we know. Whether post-discharge thromboprophylaxis is indicated in COVID-19 without other indications has been a subject to severe observational trial. The ACTION trial found that for stable hospitalized patient, rivaroxaban 20 mg once daily for 30 days post-discharge confers no additional benefit when compared to in-hospital prophylactic dose. So the ASH guideline recently updated recommendations suggest that patients should not receive such discharge prescription in absence of other indications. Suppose they are bedbound, they are still on oxygen, then you consider giving them. Otherwise, if they're ambulatory post-discharge, there is no additional benefit of giving prophylaxis at home. So to conclude, patients with COVID-19 are at increased risk of developing PE, which may occur in up to 1/3 of critically patients requiring ICU admission. High degree of suspicion in diagnosing DVT should be adopted in this patient based on both clinical and lab data. Thromboprophylaxis should therefore be started in COVID-19 patients admitted to hospital, and intermediate therapeutic dose of anticoagulation can be considered in those with high risk, where you have multiple risk factors, more than only COVID-19 and hypoxia. Extending the thromboprophylaxis after hospital discharge or in hospital pre-hospital phase during home isolation should be done according to the meticulous risk-benefit ratio. Balancing the reduced risk of ET with risk of bleeding should be done in all cases. Therapeutic anticoagulation is the cornerstone in the management of PE. Selection of appropriate agent and correct dose requires consideration of underlying comorbidities and organ dysfunction. And a big no to routine thrombolytic therapy for patients who are stable, do not meet the criteria of thrombolysis. Thank you for patient listening.
Talk, very crucial topic during this COVID. Now our next speaker. Any question from audience? Dr. Manoj? Dr. Manoj? Dr. Manoj?
Sir, your sound is echoing.
Dr. Manoj? Dr. Manoj?
Sir, Dr. Manoj left eyes.
Okay. Our next speaker is.
यार मेरा वीडियो ही करते हो तुम वहां से.
Next speaker is Dr. Sudhir Kuteka. Geeta. Director of Critical Care and Chief Intensivist, Sub Hospital, Jaipur, and he is past EC member. He is founder general secretary of Transport Medicine, published many papers in Index Journal, and fellow of Society of Critical Care Medicine. And he will speak on COVID care of geriatric patients. Dr. Sudhir.
Good afternoon, everyone. Here we are for the COVID care of geriatric patients. I thanks to organizer for giving me opportunity. I thank to the chairperson, and I welcome all audience. The severe acute respiratory syndrome coronavirus 2 pandemic has particularly high morbidity and mortality among the older segments of population. Comorbidities like diabetes, hypertension, cardiovascular and cerebrovascular disease, obesity are risk factors for worse outcomes. It's a bridge. COVID-19 is a bridge between the communicable disease and non-communicable disease, in which people of chronic lifestyle-related factors such as obesity, diabetes, hypertension, and other comorbidities have higher incidence and complication rates, including the mortality. Facts. There are certain facts that older people are facing the most threat and challenges, particularly in the second wave. Older people face significant risk of developing severe illness. The severity of disease is due to psychological changes that come with aging and potential underlying health conditions. Long COVID was more common in older people. Physiological changes in geriatric population, that's important. As age advances, their anatomy and physiology undergo many changes that becomes more apparent with increased chronological age. Aging is a progressive physiological process that's characterized by degeneration of organ systems and tissues, with consequent loss of function reserve for these systems. Loss of these reserves impairs individual ability to cope with the physiological changes. That is the basis of high mortality and morbidity of COVID-19 in elderly patients. How? The respiratory system. Respiratory system, lung and chest wall are less compliant as age advances. Total lung capacity, forced vital capacity, FEV1 and vital capacity are all reduced in chronological manner. Well, cardiovascular system, there's large and medium-sized vessels become less compliant with age, resulting in raised systemic vascular resistance and hypertension. Cardiac output falls by 3% per decade, which is due to reduced stroke volume and ventricular contractility. Similarly, catecholamine beta-adrenergic receptor are downregulated in myocardium, and subsequent effect of vasoconstrictive drugs is less potent. There is generalized impairment of autonomic hemostasis. In the renal system, GFR decreased by 1 ml per minute per year and 1% per year. So it amounts to 1% per year over the age of 20 years. Neurological neuropsychiatric symptoms. The neurology density is reduced by 30% by age of 80 years. This makes difficult communication due to visual and hearing impairment is very common in old age. Cognitive impairment occurring frequently with Alzheimer's disease, multi-infarct dementia, Parkinsonism, chronic alcoholism lead to difficulty in communication and patient compliance. Anorexia is an important thing. As age advances, their anorexia sets in. Anorexia can be because of physiological changes in the body, some pathological changes in the body, and psychosocial changes. It ultimately leads to anorexia or aging. Other systems, the basal metabolic rate falls by 1% per year after age of 30. Fall in metabolic activity and reduced muscle mass because impaired thermoregulatory control. Reduced total body water and increased adipose tissue leads to an altered volume of distribution of some drugs. Plasma proteins are reduced, resulting in decreased protein binding and increased free drug availability, causing toxicity of drugs at a very lower level. So what the effects of aging? There are increased susceptibility to infection, altered disease profile, there are decreased immune responses, different time treatment responses, limitation on treatment options owing to comorbidity or other organ failures. Henceforth, the older people exhibit different disease spectrum and different response to treatment that make essential to treat the geriatric population in a different way. Elderly people are more susceptible to severe infection than younger patients due to generally weaker immune response and presence of comorbid underlying disease. As a result, the management of COVID-19 in elderly patient much more use should be very cautiously done. In a recent meta-analysis, the most common symptom in elderly patient was found to be cough, followed by fever, dyspnea, and fatigue. The pneumonia severity index, multi-loop involvement on chest CT scans, the prevalence of acute respiratory distress syndrome, and level of CRP were significantly higher in elderly. Lymphocytes significantly lower in elderly people. The rate of acute injury to heart, kidney, and liver also, the prevalence of secondary bacterial pneumonia were higher in elderly people groups. In another study, 92% have bilateral pulmonary involvement despite having relatively mild symptoms. So symptoms may be out of proportion, maybe less. Lymphocytopenia, increased CRP levels. Pulmonary system complications, SARS-CoV-2 interacts with ACE2 receptors. This ACE2 receptor is highly expressed in alveoli and bronchial epithelium. Binding to such receptor triggers a cascade of further events leading to acute injury of the pulmonary system and pulmonary edema. Conditions like senile emphysema, muscle atrophy may lead to impaired lung functions. So as a whole, geriatric people with weak liver respiratory functions, decreased airway clearance, decreased pulmonary reservation, and weaker immune system are more liable to have more complication of respiratory system. Cardiovascular system complications, again the ACE2 expression is high in cardiac tissue, leading to increased cardiac injury. The further impaired respiratory function and hypoxia lead to exacerbation apart from cardiotoxicity associated with antiviral drugs. Drugs might trigger certain syndromes like sick-sinus syndrome, QT prolongation, torsades de pointis, especially drugs like SCQS. Liver function impairment is seen due to a direct effect of virus on hepatic cells, side effect of medication used in treatment, cytokine storm, and hypoxia related from pneumonia. The impaired liver function in mild cases are resolved spontaneously. A word of caution to be used in elderly people. Special attention should be paid to medications, especially those are metabolized through hepatic system, because polypharmacy patients and history of hepatic disease, they are more liable to get hepatic damage, and drug interactions should be considered in these patients. Renal system complications can be avoided by adequate hemodynamic support, avoid nephrotoxic drugs, early renal replacement therapy, and keep attention for polypharmacy and drug interactions. Muscle strength is an important independent factor. Share studies done in 3,600 older people that has been shown that higher grip strength was associated with a lower risk of COVID-19 hospitalization. So it's a vicious circle. Muscle weakness causes more COVID-19 severity, and COVID-19 causes more muscle weakness and muscle loss. In the elderly, skin disorders are important because of repeated contact with disinfectants, sanitizers, soaps, and detergents. The contact dermatitis develops, and there are exacerbation of previous cirrhosis and previous eczema and atopic dermatitis is there. Emergence of herpes reactivation is an important factor in these, and long-term use of facial mask can lead to facial acne and rosacea during this pandemic. Diabetic elderly, use of steroids should be with caution. Endogenous corticosteroid due to stress inflammation is there, so insulin is the best to treat the diabetes in elderly people. Some common measures to be taken medically, that's regular exercise, regular adjustment of blood sugar, healthy eating habits, increased protein intake, correlating correcting the vitamins and mineral deficiencies. All such activities will strengthen the immune system and better the immune system and milder the disease. One more thing is the antihypertensive drugs which causes decreased water volumes, such as thiazolidinediones, should be avoided. Psychological aspect is very important in COVID-19 with the elderly people. The causes of psychological disturbances is social distance and stay at home. That's advice to older people. Non-availability of domestic help, non-availability of resources for daily life, non-availability of or poor availability of medical services, medicines, and medical health services. There are fear of feeling close to death is another factor which plays an important role in psychological disturbance of older people. So the disruption of daily life through the new imposed measures, there's an important deleterious effects, not only their physical health, but mental health and psychology to a greater extent. The basic facts is increased depression and suicidality, as well as psychoendocrine metabolic responses, and finally, decreased immunological response that leads to poor outcome in elderly people. The efforts to address the need for elder people again remains very limited and out of focus and are ignored, so that should be taken care of. Important to note that older women experience more symptoms. They are worried about, older people are worried about futures, they are feeling stress, restless agitation, changes, and suicidal thoughts. Once infected, older adults with dementia are more likely to experience severe viral-related outcome, including death, and than other people with dementia. Psychology. Therapeutic measures are to be taken in with provide information with COVID-19 and protective measures so they feel secure about it. Issue practical help in case of problem with daily living, provide medical expertise and psychological support, establish helpline to assess mental health impact, and online technology might help with the social support for aged people and also help them stay connected with the society. Though some simple measures like frequent phone calls by friends, relatives, free access to healthcare counselors via phone, that's important in psychological support of older people. So measures and initiatives to support psychological needs and psychological well-being of older adults during health crisis apart from medical support. Consequently, it's recommended not to discharge them early because that needs the continuous care is to be provided to them. According to existing literature, there are many old people are now online. The majority still needs assistance when using digital technology and access the information. Most vulnerable older adults do not have access to web sources or required digital skills and knowledge for its use to be satisfied and effective. So at present, digital technology is insufficient to reach vulnerable population, especially the older people. So what to do? make them tech-savvy, making communication technology more accessible to them, provide technology use training, promote technological innovations so that the older people are more socially active. They are unable to more social interactions despite their isolation and protective measures. Long-term care, the Center for Elderly People should be developed. Robust quarantine measures should be adopted. Any suspected COVID-19 infection rapidly transferred to such patient to specialized center as soon as possible. Wearing a mask, careful hand hygiene, dealing with special attention to elderly people who are with a high risk like diabetes, cardiovascular problem, autoimmune disease, neurocognitive disorder, and mental health issues. Thank you very much.
Thank you, Dr. Sudhir. Thank you, Dr. Sudhir, for the elaborative talk. Any question from audience? Dr. Lalit? Dr. Lalit Singh?
Yeah. Hello?
Hello?
Yeah. Yes.
Any question from audience? No.
Now the next speaker is Dr. N. Ganapathy. He is a Director, Dharmantri Medical Institute, Erode, Tamil Nadu. He is a National Director of CTLS, and sir will discuss pandemic and emergency services. Are we prepared? Sir, Mike.
Pandemic and emergency services. Are we prepared? What are all the measures to taper the influence of severe pandemic? Before the commencement of pandemic or before it extends the community, we should be prepared, and the communities can be given awareness about self-protection for their residents. Social distancing policies and action must be executed. There may be scarcity of essential goods. The major and basic needs include food, water, fuel, medicine, and many more. They become scarce due to decreased production, reduced international and national cargo transport, and missed delivery. To maintain the population, stockpiles must be needed. There may be disruption of routine services. Schools, government offices, and post office may be closed. Electricity, telephone service, the internet and commercial radio and TV broadcasts also be interrupted if electric power grid falters or fails. Local automated teller machines, banks may be shut down, and cash will be in short supply. There may be threats to interrupted transportation. Interruption may be in gasoline supplies, road repair, water and utility services. They were all delayed or unavailable due to disruption of transport facilities. There may be restriction of personal movement. The travel may be restricted. Restriction on public gatherings, such as funerals, parties, and other events may be necessary. Isolation and quarantine may be necessary. What about the food security in pandemic? The potential events are global and local disruption of food supply chain due to lockdowns affect perishable food items, leading to food waste. Fewer fresh food available in the market, fruits, vegetables, dairy, lead to poor diet quality. Food system worker illness contribute to continuation of supply of chain disruption. Uneven food price effect in local context impact food import dependent countries. Altered food environment affect access to the healthy and nutritional foods. What are all the consequences? Hunger is a major constraint to a country immediate. and long-term economic, social, and development. Hunger, poverty, and disease are interlinked and are direct results of lack of sustainable food supply or availability. Less cash availability to buy the essentials, social disintegration, and supply chain disruption occurs. How are we going to prepare? Adequate emergency food aid wherever possible with local and regional purchase of food for food assistance. Ensure food system workers have access to full protection hazard and risk. Implement the mechanism to protect farmers and small agricultural producers from uncertainties and income losses such as specific insurance input transformation. Include support for individual and community responses such as home and community garden. What response we have to do? Prioritize who get food transfer. Deliver food to isolated household. Emergency food ration during crisis. Special food for hungry children in school. Enabling more supply chains. So how are we going to involve medical and health services in pandemic? The potential events are large number of sick and dying people with high levels of grief, high rates of work absenteeism in all sectors, a need to provide most healthcare in homes or in the community. What consequences we get? Healthcare facilities are overwhelmed, disruption of local leadership due to death and illness, dehydration due to pandemic illness and water shortages, increased non-pandemic deaths due to compromised healthcare services, shortage of medications and malnutrition, increased medical and funeral expenses, high levels of anxiety and uncertainty. How are we going to prepare? Make sure food acquired for emergency distribution meet nutritional energy needs, educate household proper water treatment and shortage to increase hygiene, provide training in mental health and grief counseling, negotiate low-cost credit for medical and funeral expenses. How are we going to respond? Implement measures to limit the spread of pandemic virus, encourage and support home-based healthcare for those able to be cared for a home, encourage community-based healthcare for sick persons from whom facility-based care is not available or for whom home care is not possible. Make direct food transfers to medical facilities. Conduct ongoing observation monitoring and treatment of malnutrition and provide psychological support for grief counseling. Preparedness against pandemic. 3 components of preparedness should be insisted. Prepare our program, prepare the health center, prepare our staff, and prepare our patient. To develop emergency management plan, activate emergency operations center in order to save life, protect property, and meet basic human needs. Stockpile or arrange to access to supplies, medicines, equipment through community partnership. Resources to care for sick people and essential services should be kept ready. Vaccination. Significance of vaccination. For example, if you take COVID-19 vaccine, it helps us from getting the virus. It is an important tool to help stop the pandemic. The vaccination do not affect or interact with our DNA in any way. It is a safer way to help build protection. There are several safe and effective vaccines that prevent people from getting seriously ill or dying. So what should we do and expect after getting the vaccination? So we have to stay where we got vaccinated for at least 15 minutes to see for the side effect. And we should ask when is the second dose. In most cases, minor side effects are normal. The minor side effects like arm soreness, mild fever, tiredness, headaches, muscles or joints. If supplies are limited in our area, we have to discuss with the care provider who supplies the vaccine, have a compromised immune system. In a pregnant woman, or they are already breastfeeding, we should ask whether we have to continue the vaccine and the vaccination profile. If we have a history of severe allergies, particularly to a vaccine or any of the ingredients in the vaccine, we should be reporting it to the care provider. To conclude, a timely and efficient public health response during an outbreak is critical to prevent the introduction, transmission, or spread of communicable diseases. As a global threat of pandemic diseases continues to emerge, the awareness and preparedness should be improved. The knowledge and awareness of the disease are important parameters for the adoption of protective measures that minimize the exposure risk of the illness. Therefore, the health promotion and awareness program are warranted to address a particular section of the population. Thus, awareness program and other educating strategies should be developed and implemented more effectively to eradicate the disease and increase the breadth of knowledge of rurally and minimally educated population. Thank you.
Thank you, sir, for your comprehensive and informative talk. I think will be no question for as this is very informative talk. Now the next speaker is Dr. Moid. And Dr. Moid is a director, head critical care, and in charge ICU, Jain Medical College, Aligarh. And he is a well-known figure in Indian fraternity as we discuss about the airway. On his credit, 110 publication, and he will discuss the remote respiratory monitoring in COVID patient. Now I request Dr. Moid.
नहीं फ्री हो गया वो
Respected chairpersons and my dear delegates, good afternoon to all of you. I'll bring greetings from my university and my medical college, Aligarh Muslim University, and I'll be speaking on remote respiratory monitoring in COVID patients. I have nothing to disclose. Recently, we have seen there was a sudden surge in COVID patients in the second wave, and who required hospital care. So as a result, there was a shortfall of both general beds and the ICU beds, and which led to makeshift arrangement of ward beds and the ICU as well. But these areas were being manned by ill-trained healthcare providers, and because there was inadequate facilities and inadequate equipments and infrastructure as well, so they were all causing risk to the patients along with the healthcare providers. Similarly, simultaneously, what we also observed was there was a decrease in the existing trained healthcare providers. So what was the primary concern? Primary concern was that we need to have safety of the patients along with the healthcare providers, so prevent them from contamination, decrease the healthcare provider exposure, train the freshly recruited nursing staffs or the healthcare providers, and counsel them to allay their anxiety. But this also, at the same time, we have to see that we must not compromise on the patient's management, especially their airway management, they're improving their oxygen and ventilation, and deliver point of care and improve their outcome. And also decrease the aerosol load both in the ICU and the general wards. Now, all these could be overcome by home quarantining the patients, especially the healthcare workers as well, and who are ambulatory. decrease so as to decrease their exposure to the infected areas, at the same time decrease their workload. Home isolate the infected patients, and regularly train the healthcare providers, freshly recruit the healthcare providers. And the basic idea was to decompress the emergency department or the ward so that the freshly new patients can come in. And we could all obtain this by establishing the remote monitoring system. Now, amongst the various parameters, we have seen the respiratory parameters were one of the most important parameters which were being taken care of during this COVID patients. But they were all poorly recorded. Respiratory rate was one of the most important parameter which was poorly recorded. And the most important thing, despite having clinical significance, especially it helps to diagnose the patient, prognosticate the patient, triage the patients in hospital administration along with admission, along with the ICU admission. And especially a person who's having a respirator more than 30 breaths, we saw that these patients are very critically ill and which can point out towards the severe pneumonia. The patients can also be categorized by, especially on the how much whether we need to give supplement oxygen or not. So at the same time, most importantly, we can timely detect the deterioration of these patients by just monitoring the respiratory rate, and so as to go for an early intervention in these patients. The IC mortality also depended on the respiratory rate, especially the more the patients were having a higher respiratory rate, that significantly increased the mortality of these patients. And similarly, we could also see that the respiratory rate, when it came down to normalization of the respiratory rate, which clinically indicated that the patient is going to recover, coming to a recovery phase. So there are certain hospitals who have used an algorithm where they made 3-tier system. The first tier, where the patient was having the respiratory rate more than 24, and then these patients could only be monitored, or only could be managed by giving oxygen. But when the moment the patient went to when the respiratory rate increased more than that, they were shifted to second tier, and subsequently to third tier, the moment the respiratory rate were more than 30, who needed immediate intubation. So, but one very important thing is that all these days we were monitoring with initially we were monitoring with the mounting, with the manual monitoring, which were, and at the same time they were self-reporting, especially those patients who were home quarantine or they were isolated. These patients were manually counting and they were self-reporting, but it was all biased, and they were being since they were aware, so they were not giving accurate finding of their finding, and that led to a lot of problem. So the accuracy needs to be maintained, and this could only be maintained by using sensor systems, and the techniques could be a bit different than the manual counting. So the institution hospitals, they came up with the high definition CCTV. They were installed in the wards and in the ICUs as well, which could monitor the mechanical ventilation along with the respiratory around the clock. And there were also remote mobile health monitoring devices, which could, especially the smartphone, with the help of which one these were offsite located, and they could monitor the respiratory rate along with the mechanical ventilation. But they were not that much accurate and precise. So there were some technological solutions which came up, and which were again divided into 2 categories. One was the periodic short-term screening, where they had built-in cameras in the smartphones and laptops, and which could record the chest wall movements, and the accuracy was pretty good. They had less than 1 breath per minute error. And they had again a continuous monitoring system, which was again on the basis of microphone chips, which was detect the sound waves, and especially when the breathing sound, and they can monitor the respiratory rate and the mechanical ventilation as well. So they had also pressure systems which could be installed in there underneath their mattress, and that can also, with the help of the movement, they can identify the respiratory rate. And these are the designs which with the help of which they could monitor the respiratory rate. One is the microphone system, and the other is putting a chip underneath the mattress. and they can either help with the help of tablets or laptops or a smartphone. They can identify in a remote place. And there are other contact-based methods of measuring respiratory. That is respiratory airflow, respiratory sounds, respiratory air temperature monitoring, air humidity, air components, chest wall movement, and modulation of cardiac activity. These are all contact-based methods by the help of which you can monitor the respiratory rate and the mechanical ventilation. There was another device which was, a ear aid, which could, with the help of plethysmogram methods, they can identify the vital signs, especially the respiratory, the SpO2, and the heart rate. This was again a device which could be installed. Dozy came up with an artificial intelligence device which was integrated into a single central patient monitoring triaging the platform, and they could monitor more than 3,000 patients at a time, and a single person is monitoring. So naturally, that significantly reduced the nursing hours, and at the same time, they prevented the exposure of these patients to that contaminated area or infected area. Similarly, W4 also came up with an tele-ICU method where, with the help of centricity high acuity critical care solution, where they could connect more than 800 beds, having a single hub hospital, and which was manned by a skilled healthcare professional. So naturally, the exposure of the professional is reduced, the workload of the professional is reduced, the time of nursing care is reduced. So all these benefits could be achieved with the help of these remote sensing system. So the advantage is flexible, they are flexible, agile, and more economical, and they could be used, the parameters could be monitored remotely without exposing the persons at risk, and at the same time without compromising the patient's healthcare management. Ensures continuous vital physiological monitoring, and most importantly, if there's sudden clinical deterioration, they can detect early, and accordingly early interventions could be taken, and naturally ensures quality healthcare, limited resources with the limited resources and personnel as well. And even the quarantined healthcare workers can also participate in the healthcare management. But there are disadvantages as well. One should not be carried away with a single parameter. One has to take care of, consider the other parameters as well, so as to reduce the mortality. And we have to set a target while we are, or endpoint while we are using this method or monitoring system, because otherwise we will be delaying the patient's admission, and that could lead to mortality. So the key points are there was a sudden increase in COVID patients we have seen, and requiring hospital care, which led to establishment of general ward in any area, and an ICU which was not manned by trained personnel, and the equipments were not as per the standards. The facilities were not as per the standards, and that could cause the existing staff to be at danger, or the patient to be at risk. So the primary concern was to make the area safe, the patient safe, and the most importantly, the healthcare workers safe, and at the same time decompress the hospital so that the fresh patients can come in. And so naturally, we have to establish certain system with the help of which we can do this. So monitoring maximum patients with a single intensivist or single healthcare providers was one of the most important goal, and which we could do it with the help of establishing a remote monitoring system. And respiratory was considered one of the most important monitoring system which could do this, so which can help in diagnosing, prognosticating, triaging, timely detecting the patient deterioration, and early intervention. All this could be done with the help of respiratory, one parameter, but other parameters should also be considered simultaneously. High definition CCTV could be one method. Remote mobile health monitoring system could be the other method. There could be periodic short-term screening, or it could be continuous monitoring system. Dozy has come up with the devices which are really good, and W4 tele-ICU, they can also have a monitoring system which can monitor not less than 3,000, more than 3,000 patients at a time, with a single person monitoring a particular area. And so naturally exposure of these patients, of these healthcare providers, workload of these healthcare providers could all be reduced with this remote monitoring system. But one most important thing is it has to be accurately monitoring this. So it should be a robust and a independent equipment, and should be performed alongside the monitoring of other vital signs as well, so as to counter the COVID-19 crisis. Thank you so much for your patient hearing.
Thank you, sir, for such a wonderful session. Are there any questions? Thank you, sir. Now, I would like our chairperson to introduce our last speaker for today, Dr. Juhi Chandwani.
Good evening. This is the last session of this thematic session. The last speaker is Dr. Juhi Chandwani. She is a senior consultant anesthesiologist in Intensivist Royal Hospital, Oman, and she will discuss the it's COVID or secondary pneumonia or both. I request to Dr. Juhi Chandwani, please continue her talk.
It's COVID or secondary pneumonia or both. Now, during the viral pandemic, secondary bacterial infections affect mortality rather than the hypervirulent virus itself. An autopsy series from 2009 H1N1 pandemic found evidence of bacterial co-infection in about 30% of the deaths. Hence, stockpiling antibiotics and vaccines against this bacterial pathogen is an important factor in pandemic preparedness. The clinical spectrum of SARS-CoV-2 includes mild upper respiratory tract disease to asymptomatic subclinical infections. About 8 to 20% of the patients get hospitalized, and among those getting admitted to the ICU, the mortality rate increased to 50%, especially if they go on the ventilator. In-hospital death of patients with pulmonary secondary bacterial infections were 2 times higher in COVID-19 patients, as was seen in a study done by Pirath et al. In fact, they found that withholding antibiotics because of missed or delayed diagnosis was found in 24 to 40% during the influenza pandemic. This is because of the confusion whether to give antibiotics or not to give antibiotics because of the fear of antimicrobial resistance developing. And we know that we are treating viral pneumonia. However, because of this increased risk of death in patients with COVID-19, the WHO recommends giving antibiotics to all suspected or confirmed COVID-19 cases on identification of sepsis within 1 hour of the presentation. In fact, they found that almost 20% of the severely ill COVID-19 patients had co-infections or superinfections, and this might be a significant yet a treatable condition and can reduce severity among COVID-19 patients. So what are these co-infection and superinfections that we talk about? CDC defines co-infection as one occurring concurrently with the viral infection. Superinfections are those infections that follow on a previous infection, especially when caused by organisms that are resistant or have become resistant to the antibiotics that were used initially. Now, an interesting study by Bamford and Bagicha have found 3 possible correlations. That is, that either the virus secondarily affects following a bacterial infection or colonization in the patient, or the patient has both viral and a bacterial pneumonia, or a secondary bacterial superinfection develops in patients who is already infected with SARS-CoV-2. Irrespective of the sequence, the combination is always lethal. That is because the bacteria and the virus, they go hand in hand. The viral infection compromises the immunity of the patient, and influences bacterial attachment, growth, and dissemination by releasing the mediators. Moreover, it uncovers the bacterial receptors and makes it easy for the bacteria to stick to the mucosa and to lead to invasive infection. On the other hand, the presence of bacterial infection compromises innate immune host defense and leads to viral survival, replication, and pathology. Together, when the virus and bacteria co-infection is present, it leads to tissue damage of the respiratory epithelium, and this leads to release of the inflammatory mediators and leads to a very heightened inflammatory response, which we have all seen during the COVID-19 infections, and these almost always has worse outcomes in the patients. If that is not enough, the COVID-19 therapies that we use for the patients, which are the anti-inflammatories and the biologics, which target the cytokines, they further propagate bacterial co-infections because they are all immunomodulatory interventions which increase the risk of these lethal secondary bacterial infections. However, when the patient presents to us, it might be within the first week or it might be on the second week, depending on the time of deterioration in the trajectory. The patient might have features which might replicate either a normal pneumonia with bacteria like pneumococcal, staphylococcus, or Klebsiella, or viral pneumonia due to other viruses, or a fungal pneumonia or tuberculosis. It's very difficult to differentiate based on the clinical and the biochemical parameters or the laboratory parameters that patient presents with commonly. Even the radio X-ray may look similar in the pandemic viral pneumonia and the pneumonia due to other causes. So it becomes a big dilemma whether to treat them with antibiotics or not. Treating antibiotics leads to the risk of antimicrobial resistance. In fact, during the pandemic, the social distancing, the wearing of face masks, and the hand washing that we practice, including isolation of the infected cases, have led to reduction in the acquisition of the common bacterial infections and hence less use of these antibiotics, and in fact has improved the antimicrobial resistance. On the other hand, the rampant use of hand sanitizers and the antibacterial soaps contain certain chemicals which fuel bacterial antimicrobial resistance. So the empirical broad-spectrum antibiotics, which are commonly used in these patients to target this co-infection and superinfections, they have limited effect on the superinfections which patients develop subsequently. And we all know from the studies that 15 to 50% of the bacterial isolates are already resistant to one or more antimicrobial groups. Hence, inadequate broad-spectrum empirical antibiotic use could be associated with higher mortality, especially when these viral pneumonia patients present with sepsis and septic shock in the hospital settings. So we need to exercise caution. We can't use antibiotics rampantly in every patient. A study done by Vaughan et al., which was published in Clinical Infectious Disease, found that we have used antibiotics in 56% of the patients, while only 3.5% had actually confirmed evidence of bacterial pneumonia. So what is the solution? The solution is we need to objectively determine the presence of this co-infection and superinfections. We need to know what organisms we need to target, and we need to choose these antibiotics wisely. And by keeping in mind the bacterial spectrum in this specific group of COVID-19 patients. Now, one such study, which really gives a good insight into these co-infections and superinfections in COVID-19 patients, was done by Neo Shafran from Israel. Now, this was a retrospective study of secondary bacterial infections in COVID-19 patients, comparing with the influenza patients, where they compared early infections, that is after 48 hours of admission, by checking their blood and sputum samples. And they found that all COVID-19 patients had a significantly heightened inflammatory responses like high CRP levels, WBC counts were marginally higher, ferritin was way higher, LDH was higher, and They presented with severe clinical deterioration, and moreover, most of the COVID-19 patients had co-infections. And not only one, in fact, many of them had more than one co-infections, and they had longer hospital stay. Coming to the type of the organisms, they found that 75% of these infections were gram-negative bacteria, and for organisms that grew late in the course of the illness, were more commonly due to gram-positive bacteria. That is almost to the extent of 28% versus 9% in influenza. And 85% of the secondary bacterial infections were seen in the blood cultures rather than the respiratory samples, of which only 14% came positive. Overall time from admission to bacterial growth was longer in COVID-19 patients. Up to 8 days they took for the infection to grow, compared to 3 days in influenza patients. The type of organisms grown were Pseudomonas aeruginosa, 32%, Staphylococcus and Staphylococcus aureus, almost 22%. Then, and also there was a significant difference in Enterococcus infections, where higher number of COVID-19 patients develop Enterococcus infections. And in terms of late infections, they found organisms like Corynebacterium striatum and Klebsiella pneumoniae. The number of co-infections, independent of the age, CRP, saturation, and the albumin levels, showed higher propensity for mortality, and decreased survival in these patients was found when they had more than 2 co-infections. Okay? Hence, they recommended careful surveillance and prompt antibiotic treatment in select group of patients. However, because of this confusion which prevails, starting antibiotics may not be an option for all the patients, but one thing that will surely work for all the patients is the infection control measures. These should be implemented for all COVID-19 hospitalized patients. Moreover, we need to modify the antibiotic treatment protocols, and we need to objectively determine the presence of co-infection and superinfections. And in that, the biomarkers play a very important role. The biomarkers that are studied are the CRP, cytokines, procalcitonin, and the combination biomarkers that which will be seen shortly. Now, in different times of stage of the disease, the biomarkers, the level of the biomarkers rises accordingly, which we'll see. Now, CRP, when patient presents with viral pneumonia, will always be much lower compared to patients who present with secondary bacterial pneumonia, where the CRP has to be above 60. On the other hand, cytokines measurements, which is interleukin 1 and 6, which is again has gained popularity during this COVID-19 pandemic, has shown promising results in identifying viral pneumonia. Present at levels of above 24, significantly predicted hypoxemia in COVID-19 patients. However, the turnaround time for interleukin levels is very high, and these tests are not easily available in all the centers. One biomarker which is widely available nowadays and has shown promising results, especially during COVID-19 pandemic, is procalcitonin. Now, this significantly decides the continuation of the antibiotics. A major systematic review done by Kamath et al. Did not show a major difference in the outcome of the patients when procalcitonin was used to start or to stop antibiotics. However, further studies have definitely confirmed that a cutoff value of 0.25 is a safe level to discontinue or withhold antimicrobials, especially when all the cultures are negative. A level above that may support bacterial infection and may justify antimicrobials. However, for that, the level needs to be much higher. It has to be above 0.5, and with above 2 is a sure shot indication of a bacterial pneumonia, and the antibiotics have to be prescribed for these patients. Up to date, still encourages discontinuation of antimicrobials with a value less than 0.25. Another combination ratio which has been suggested by a study done by Amal Garamti is a ferritin procalcitonin ratio, which they found that a level above 877 has 11-fold increased odds of COVID-19 compared with bacterial pneumonia. Another combination biomarker, that is Febri-DX and immunoexpert, which uses a combination of CRP, interferons, and tumor necrosis factor, again has shown promising results, as seen in the study done by Henry Carton. And they found that it definitely helps in reducing the inappropriate use of antibiotics. So based on all these studies, the consensus recommendation is that in suspected bacterial co-infections, particularly in more severe COVID-19 cases, antibiotics should be commenced while awaiting the RT-PCR results and the culture results. And the patient should be thoroughly investigated with respiratory samples and blood cultures. If all the cultures are negative, especially if the procalcitonin levels are low, it may be reasonable to discontinue. And if the microbial results indicate the presence of infections, the treatment duration should be shortened and the spectrum should be narrowed. And targeted antibiotics should be given based on the data. The hospital-acquired or ventilator-associated pneumonia infection also should be treated based on the microbiology data that we have, plus keeping the local resistance patterns in mind, and should not be continued for more than 7 days. These are some of my take-home messages. Thank you.
Thank you, Dr. Chandwani, for your comprehensive talk. Is there any question from the audience? If there is no question, then can I ask one question to Dr. Chandwani?
Sure, sir. Yes. Yes.
Yeah. What is your practice in that country, in Oman, if the patient with suspected or COVID positive presented in emergency room, what antibiotic, what investigation would you like to prefer, and what is the protocol over there?
Yeah, so over here, as we have seen in most of the sessions, the baseline investigations are always your CBC and your metabolic profile, your ABG to see the severity. And then apart from that, we had a practice of doing ferritin levels and LDH for most of the patients and D-dimers. And then as the pandemic progressed, we realized that D-dimer is of not much value. And moreover, in fact, even we ran out of the reagent for some time. So then based on the studies that evolved, we decided to change our anticoagulation profile for ferritin. Now, when it comes to antibiotics, our A&E has a practice, anybody who presents with fever and pneumonia, they give ceftriaxone 2 grams standard to everybody in the A&E. But when they come to ICU, especially when they reach ICU, we don't really continue antibiotics. We give them steroids as it is predicted, remdesivir depending on what stage of the disease they are, if they are within 1 week. And then tocilizumab we give depending on the other inflammatory parameters and the ferritin. So antibiotics we really started restricting, especially much later when we realized that, everybody started reporting, and we are giving all immunosuppressant drugs, your tocilizumab, your steroids. So we needed to be careful giving. So we started doing more cultures and following up the patients more closely rather than empirically giving antibiotics. So our infection disease also were very strict about that. Yeah.
Okay, very good. You also know the culture report, so most of the time is negative. You people are not recommending procalcitonin level at the time of starting or de-escalating the antibiotics?
Well, as I told you, when they come in the initial phases, we don't really do procalcitonin. But if the fever doesn't subside after 7 days, 8 days, when they are with us, and this time we know that, there might be a possibility of secondary infection rather than the viral phase, then at that stage, we do procalcitonin. And then we look at the cutoff as we have mentioned. If it is less than 2.25, we definitely don't give antibiotics. Above 0.5, if the patient has sepsis and end organ dysfunction also, then we consider antibiotics surely. Yeah.
Okay. And patient with sepsis or septic shock with COVID on immunosuppression drug, would you like to start carbapenem or beta-lactam antibiotics in your ICU, or you will wait for a culture reports or PCT level?
No, all the time we are not able to wait for the culture results, because as we know, in 50% of the patients, you may not have any positive cultures. So, but our standard practice is to use either augmentin to start with, and then we upgrade it to tazobactam, And then only when we have some positive cultures or in very severe septic shock, like, patients are on high inotropes and all, and if there are some colonization, some organisms are seen, then we use carbapenems and your covering MDRs, MRSAs, or VREs, whatever is the screening result that we find. Yeah, we screen the patients very aggressively, all of them. Yeah.
Thank you. Now, last question: how frequently you are encounter with fungal infection in COVID patients? In your
Sorry, how often?
Encounter with fungal infection in your clinical practice?
Oh, yes, yes. Actually, it was not very common this time we saw in our pandemics. In fact, only in patients who stayed in the ICU for very long time, on ventilator for long time, after tracheostomy and all, only then we saw fungal infections. Otherwise, we really didn't see so much fungal infections, and empirical cover we avoid unless patient has some intra-abdominal reasons, or the Candida score is high, like they are on TPN, not tolerating, long duration of lines. Those kind of patients only we used antifungals. Otherwise, we didn't really use empirically that much antifungal.
Thank you, Dr. Chandwani, for an excellent talk. And now we conclude the session. And
Dr. Lalit, can I ask one question to Professor Mohit?
Ranveer Tyagi is our colleague, and
Lalit, can I ask one question to Professor Mohit, sir?
Please, Mohit. Dr. Mohit, sir, you are muted, sir.
Yes, sure.
My question is remote respiratory monitoring.
Yeah.
So, any criteria to transfer the patient from remote to higher center after the monitoring?
Yeah. So as I said, actually, the advantage with this remote monitoring is that, can you hear me?
Yeah.
So in these cases, the best part is that you can monitor these patients when the patients are at home as well. So that you need to set up an end target. The endpoint has to be very properly set, and that is as per the universal standard, that the moment the patient crosses 24 to 30, then naturally you need to 24 is it should be the cutoff margin that the patient is being remotely monitored. The moment patient comes to 24, you need to shift the patient from home quarantine or any other ward to an ICU, and the moment patient crosses 30, it's the time that you need to have to go for either non-invasive straight away, or you've got to go for an intubation. But they are not an independent parameter on which you have to base your management or shifting, but they should be collectively dealt with the other parameters as the SpO2 and the blood pressure, the hemodynamic status as well. So, but the point is, yes, respiratory rate is one of the most important early sign which tells you that the patient is going to deteriorate, and that helps to pick up these patients very early. And that is why remote monitoring is really helpful especially when a situation like which we have faced in the second phase. Really, there was acute crisis of staffs, healthcare providers. So we can keep these patients at home quarantine. Those patients where we think that they can avoid putting the patient in hospital. So this is the best part of it. But as I said, you have to set up an end target, especially 24 is the cutoff margin and 30 is when you need to intubate.
Dr. Mohit, sir.
Yes, sir.
How reliable this remote monitoring once you know the patient in hypoxia and patient relative is illiterate and they are
see the most important part is these patients are happy hypoxic, so naturally till the end of it they will tolerate this hypoxia very well. But the most important point is naturally that is why you will see that most of the patients are also tending towards cyanosis, but they're cyanotic, but they're still they are very comfortable and they're not having any sort of respiratory distress to that extent which we expected. So that's why I said you have to keep a margin at a window period, and that is where you have to keep the patient at 24. And yet at the same time, not a single parameter should always be your cutoff margin. You should also see the ABT, where PO2 tells you an indication. It gives an early indication, and SpO2 also gives an indication. So if the patient is having an SpO2 of say 80%, and the patient is having a respiratory rate of 24, but that does not mean that you have to quarantine this patient. You need to bring the patient straight away to the hospital and treat the patient, because that single parameter should not be taken as the endpoint. That's the point. But of course, yeah, if the patient is 90% saturation or 92% saturation with respiratory of 24, you can jolly well keep the patient at home, at least, because you don't need to overcrowd your hospital, because let the people who are really critically ill, they should come to the hospital, and then you can manage them there as well. So this is one of the best important factors. Yeah.
Thank
Yes,
you.
sir.
Thank you, Dr. Mohit. But I think this is a topic of debate, because patient on remote area, patient with 24 or 26 or 30 respiratory rate with bilateral floppy shadow, most of the time cyanosis, the relative won't recognize, and patient immediately shifted to nearby hospital with a gasping state, rather than waiting and asking what is your respiratory rate and what is your status in home. What is your comments on that?
See, that, as I said, that single parameter should not be considered to shift the patient to an hospital. Now, first of all. Secondly, that these patients, when you're thinking that the patients are far off from your hospital point, that means you have this should be within a location of say 1 to 2 kilometers, where you think that the patient can be immediately shifted to your nearby hospital center. So these are the patients, or you can say that yes, the patient is very close to your hospital. Instead of putting the patient in the hospital, let the patient be in a home center where the patient can be monitored and care. Now, there are much more critically ill patients who have not been given a space to survive and space to manage in the hospital. So you have to triage your patients. This is where this remote respiratory rate helps you. It helps to triage these patients, which patients are very critically ill. They can be brought in early. And those patients who are really relatively, they can be monitored at home. And then again, the monitoring system should not be like it is around say 10 kilometers, 20 kilometers away from your hometown, then from your hospital, then it obviously that's not the way to tackle this. They are very close to your hospital, where you think that yes, the patient can be monitored at home. It's better that let the patient be monitored instead of bringing the patient to the hospital. But there are much more critically ill patients who has to be given the priority, keeping in mind the respiratory rate and the SpO2 and the PO2. That's my point. But yes, as you said, the patient is cyanotic and there's no one to monitor. See, this I said, now there are certain things which, addition to your remote sensing, because you're going with a smartphone, you're going with the the laptops, the tablets, which helps you to identify the patient, visualize the patient. So from your remote place, you can also visualize the patient, as there are certain gadgets which helps you to visualize the patient, along with they help to sense your respirate with the sound waves and with the pressure waves as well. So you can use both the devices, and then you can monitor even at a distant place.
Yeah, you have seen in second wave, we lost most of the patient because the authorities say you just monitor the patient at home. And once we receive the patient, this type of patient in emergency or triage area, they were in a very bad shape.
Yeah, but let me tell you, there was no option for us.
You also know the health status and
that's what I'm saying.
In private sector.
Exactly, as I said, I'm in a government sector, so naturally we did not have any option to tell them, because we did not have any choice. So all the patients were pouring in. But let me tell you that even when they were poured in, we could not give the health facility. Despite their pouring in, we could not do anything, because oxygen is not there, beds are not there. Even the patients were dying even before entering a hospital. So the number of patients which are coming in, if we could have tried these patients, probably we could have at least given the priority to patients who are really salvageable. The salvageable patients should be given the priority, instead of going for at random to all patients and not managing the patients who can survive. So this is the problem which we could not do with only because the patient came in pouring in as floodgate, and it was opening the floodgate. All the patients came in at the same time. So that is what I was telling. That is my point. That if you somehow can triage this patient to an extent where they can be at least giving a window period of 1 to 2 hours, probably meanwhile you can triage the patient which are much more seriously ill, and you can at least manage those patients. This is my point. Otherwise, obviously, you don't have any choice. You have to take all the patients, especially for us working in the government sector.
Yeah, I fully agree with you. It's just a double-throat system. Otherwise, it's very difficult.
Yeah, exactly.
Thank you, Dr. Mohit, Dr. Chandwani. Now the very wonderful interactive session. Now we conclude the session, and thank you all.
Thank you so much.
Thank you, sir. Thank you. Thank you. It was an excellent session. Thank you to the chairpersons and the organizers. Thank you.
Same here.
You all take care. Bye-bye.
Bye.
You too. Thank you. Take care.
Take care.
Thank you,
Stay,
everyone.
stay safe. Stay safe.
Now we conclude all the sessions for today of Hall B. Thank you for your wonderful presence.
Thank you.
अभी ऑगमेंटेड चल रहा है ऑगमेंट ऐसा चेंज करो उसकी काम करते हैं 10,000 कर दो कितने होगा 18,000 और क्लेम नंबर ऐसा उनको दे देना